Good Good afternoon, everyone. I'm Tomoko Fuji from GK University Hospital, Tokyo, Japan.
And I'm Marlies Ostermann from London, UK. I will chair the first half of the session, and then my friend and colleague Melanie Mersch-Dini will take over.
Thanks. And we have an absolutely stellar lineup of speakers today, so welcome to this special session on the renal replacement therapy. And I'm very excited and incredibly honored to be here. So let's get started. The first speaker is from France, Dr. Stéphane Gaudry. Want to start?
Thank you very much. Okay, so I would like to thank the scientific committee for the invitation. I have no conflict of interest regarding this topic with the industry. However, I received grants from French Ministry of Health to conduct several randomized controlled trials on renal replacement therapy in ICU. At first, I would like to pay tribute to Dr. Christophe Vincenot. He was an intensivist in France and a very famous researcher, and he passed away last year. He published this very important randomized controlled trial on RT modalities in the Lancet in 2006. So the question of the timing of RT in ICU is a very old question because the specificity of acute renal failure is the reversibility. And the natural history of acute kidney injury is here. The start is the kidney hit, and then there is an increase in severity of acute kidney injury, and few hours or few days after the first hit, there is a recovery phase. And the question is that when life-threatening conditions occur, we should start renal replacement therapy in this natural history. And an hypothetical solution to avoid life-threatening condition is to start very early a preventive renal replacement therapy approach. And this solution has been tested in 2009 in this randomized controlled trial, including patients at a very early phase of sepsis, very early phase of acute kidney injury. And as you can see, renal replacement therapy was associated with increased organ failure compared to no renal replacement therapy. And why? Because RT is associated with many complications: hemorrhage, thrombosis, bloodstream infections, hemodynamic instability during the session, and several metabolic adverse events such as hypophosphatemia. And another complication has been explained is in this very old article. The hemodialysis may delay renal recovery. It was a concept published 50 years ago, and I will show you that this concept has been confirmed recently. So in daily clinical practice, the intensivist should assess different clinical and biological data to answer the question, when should I start renal replacement therapy? So they can assess a blood urea nitrogen level, the level of serum potassium concentration, or the pH value, or their urine output. It's a difficult discussion with the staff. However, we have three conditions in which we have to start very early. Those are refractory severe hyperkalemia, refractory severe metabolic acidosis, and refractory pulmonary edema. And these indication has been considered as absolute indication by KDIGO guidelines. What are the data on this life-threatening complication? We have not a lot of data, but for pulmonary resistant diuretic, the ELAINE trial answer the question, because in this trial many patients had fluid overload or worsening pulmonary edema, and in this trial, the early initiation of RT was associated with increased survival. This is the word from Norbert Lamer, a previous editor-in-chief of Nephrology, Dialysis and Transplantation. He said that this trial investigated the effect of delaying RT in patients who really need it, because we know that severe pulmonary edema is an indication for RT in ICU. So the real question is, in critically ill patients with severe AKI and who have no life-threatening complication, should we delay our RT? And the adequate study designed to answer the question has been published by Paul Palevsky 15 years ago. And it's to compare strategy. An early RT strategy in which every patient will receive RT, and a delayed one in which some patients will receive RT because they will reach pre-specified criteria, and the other patients will not receive RT because probably they will recover. So 3 large randomized controlled trials have been published on this question: AKIKI trial, IDEAL ICU, and START AKI, and 1 individual patient data meta-analysis. In the AKIKI trial, the first randomized controlled trial on this question, 620 patients were randomized in this trial, and we include adult patients with invasive mechanical ventilation and or catecholamine infusion with a severe acute kidney injury defined by KDIGO stage 3. And in the early group, patients receive RT within 6 hours after acute kidney injury stage 3. In the delayed group, patients receive RT only if they reach pre-specified criteria. And you can see that these first 3 criteria are the life-threatening conditions: severe hyperkalemia, severe acidosis, and pulmonary edema due to fluid overload. And the 2 last criteria are safety criteria: oligoanuria for more than 3 days, and serum urea concentration greater than 40 millimole per liters. The result is that in the delayed group, almost 50% of patients never receive renal replacement therapy, which is a very important difference between the 2 strategies. But the primary outcome was, of course, the survival after 60 days, and there was no difference between the 2 strategies. However, a secondary important outcome was the adequate urine output with no need for RT. This is a kind of approximation of renal recovery. And if it is a good approximation, we can say that the delay RT strategy is associated with a more rapid renal function recovery. It was the same with spontaneous creatinine decrease in AKIKI 1. So, as I told you, possibly hemodialysis or renal replacement therapy could be associated with a delayed in renal function recovery. This is the emergence of a new concept. It was the re-emergence of artificial kidney-induced kidney injury. And early RT may act as a second hit on the kidney during the recovery phase. The IDEAL ICU trial was published 2 years after AKIKI with the same result, but the patients are only septic patients. And you can see that in the delayed group, almost 40% of patients never receive RT, and there was no difference in terms of survival. And these results were confirmed in the individual patient data meta-analysis published in 2020. And in this meta-analysis, we include AKIKI patients, IDEAL ICU patients, and also ELAINE patients. But it was before the publication of START AKI, the largest trial on this question, a multi-center international randomized control trial. And the START AKI trial confirmed all these results. There is no difference in terms of mortality between the 2 strategies. However, and it is probably the most important point on START AKI, the START AKI trial confirmed the concept of artificial kidney-induced kidney injury, because after 90 days, in the early group, you can see that 10% of patients were dependent from RT compared to 6% in the delayed group. And it is very important, 90 days, it is the limit between acute kidney disease and chronic kidney disease. So we can say that START-AKI confirmed that early RT strategy is associated with the risk for chronic kidney disease. So we can say now with a high level of evidence, and it has been endorsed by recent guidelines on sepsis, that in the context of severe AKI and in the absence of life-threatening complication, we can delay RT initiation. It's now not the question. But the question is the optimal window to start renal replacement therapy when you choose to wait. And major uncertainties remained concerning this duration without renal replacement therapy. And it was the objective of AKIKI 2 trial to answer this question. And remember, in AKIKI 1, these 5 criteria for RT, this one, we are not going to discuss this one, but these one are only safety criteria. And we asked if it was possible to postpone RT even in this context. So it was a randomized controlled trial, but we start with an observational stage with patients with AKI stage 3. And if patients reach one of the 2 criteria, the safety criteria, serum urea concentration greater than 40 millimole per liters or oligoanuria for more than 3 days, they were randomized in a standard delayed RT strategy, the same delay strategy than in AKIKI 2, in AKIKI 1, and a more delayed RT strategy. In this strategy, renal replacement therapy was started only in case of life-threatening condition or in a case of serum urea concentration greater than 50 millimole per liter. We include almost 800 patients in the observational phase and 278 patients in the randomization phase. And the primary outcome was RT 3 days, which is a kind of composite outcome because it's include the RT exposition and the mortality in this primary outcome. And as you can see, there is no difference between the 2 strategies in terms of RT 3 days. But one very important result is that in a pre-specified multivariate analysis, the more delay strategy was associated with an increased risk for deaths compared to the delayed one. So it was a very important trial because the window is now defined. We should not wait more than 3 days. Is it 2 days or, I don't know, 55 hours? We can't answer this question. But we know that 3 days, it's the limit. And to explain the result, we hypothesize that probably hyperuremia may have neurological may lead to neurological problem in these patients. So we conduct this post-hoc analysis on patients with coma, and we include 168 patients, comatose patients, in this secondary analysis. And the primary outcome was the transition intensity from coma to awakening during the 28th first day after randomization. And the result is that this transition intensity from coma to awakening was lower in the more delay strategy group. And it was confirmed in 2 sensitivity analyses. So it's very important because I think on a case-by-case patient, we can discuss the indication for RT in comatose patients. So I will summarize the talk with this last slide. In context of acute kidney injury in ICU, if this acute kidney injury is severe, the first question is to ask, is there any life-threatening complication, hyperkalemia, severe metabolic acidosis, or severe pulmonary edema? And if there is one of these complications, you could start medical treatment. But if these complications are resistant, are refractory to medical treatment, it's the indication to start RT. In the absence of this life-threatening complication, the largest randomized control trial, AKIKI, dialysis, START AKI, all confirm that we can wait. And the AKIKI 2 trial say that we can wait, but no more than 3 days after the occurrence of severe AKI. And be careful, because I think that we can say now that if we use early ART initiation, there is a risk for artificial kidney-induced kidney injury, a risk for chronic kidney disease in our patient. It was very well demonstrated in START AKI trial. Thank you very much for your attention.
Thank you very much, Professor Gaudry. Any questions from the floor? Probably we can take 1 or 2 quick questions. No? So you mentioned that the wait-and-see approach and delayed approach has the highest quality of evidence on this topic. And do you think any interactions with modalities or doses you apply to the patients, if you think about the timing of starting the RRT?
It's a good question. The question of the dose and renal replacement therapy modalities have been assessed in post-hoc analysis of these trials. And we can say that in START AKI trial, the modalities were not exactly the same, because in France we use 50% of intermittent and 50% of continue. And in Canada, in Australia, and in START AKI, we had included 700 patients in France. But for the other country, the modality, the first modality was, I think 70% or 80% it was continue. And I don't think that changed something, in my opinion. There is no data to say that the question of the timing is interfere with the question of the modality. The real problem is the history of research on this field. We start with the question of modality. 20 years ago, we had many randomized controlled trials on modality, continue versus intermittent. But at this time, we did not know which patient need RT. Now we know. So now we have to move on and go to new randomized control trial on modality.
Wonderful, thank you.
Okay, Stéphane, I have one final question. Would you accept that people need or require RRT for different reasons? And there are people who may need renal replacement therapy just for pulmonary edema or for really refractory hyperkalemia, independent of their creatinine. And therefore, this idea that you can, if you have severe AKI, stage 3, and you can wait up to 3 days as been proposed, may not work for everybody, because there will be people who should not, where renal replacement therapy should not be delayed even in stage 1.
I agree with you. Life-threatening complication, for example, pulmonary edema, we should not look at the severity of AKI, even if it's AKI stage 1. But you know, like me, that in the vast majority of our patients in ICU, they have KDIGO stage 2, in the vast majority. But I agree with you, and this is a message, life-threatening complication not depend from the severity of AKI.
Okay, great. Thank you very much.
Thank you very much
for setting the scene. We now move on to anticoagulation, and it's a great honor to welcome the Queen of Citrate, Professor Tolwani from Birmingham, Alabama in the US, who developed citrate as a concept and has a patent in citrate. So the floor is yours, Ashita.
Thank you for that very kind invitation. Introduction, and I want to thank the organizers for the kind invitation today. As you know, I'm going to talk about citrate anticoagulation, and I'm going to talk about why and how we use it. So first of all, Here we go. These are my disclosures. All right. So I think this is going, let's see. There we go. Okay, so first of all, why do we need to think about anticoagulation for CRT? Well, CRT stands for continuous renal replacement therapy. We need to have it run continuously in order that we can provide the patient, deliver the desired dose that we plan, to also achieve the daily fluid balance that we want for our patients. We want to basically minimize clotting so we can have continuous functioning of the circuit. We also want to minimize blood loss in the circuit. But there are other factors besides patient factors. Increasing the cost of circuits occurs if you have increased clotting of the system, and of course it also increases nursing workload if the system frequently clots. So it's very important that we provide some form of anticoagulation for these patients. So these are the various types of anticoagulant regimens that have been proposed in the literature, and what we're going to focus on is regional citrate anticoagulation. So why are we going to focus on this? Well, if you look at the studies that have been done comparing citrate to heparin, there's a signal that citrate is better in terms of circuit patency. These are the KDIGO guidelines, which are now over 10 years old, which suggest that citrate is a recommended anticoagulant for CRT unless there's a contraindication. And contraindication refers to states where you have liver disease or increased shock with increased lactic acidosis. This is a summary, a meta-analysis of the different randomized trials that have been done comparing citrate to heparin. And as you can see, as I mentioned before, in this meta-analysis of over 1,600 patients, there was less circuit loss with citrate that was statistically significant, less bleeding, no difference in metabolic alkalosis, since we know citrate can cause alkalosis, and no difference in mortality. This is the largest randomized trial comparing citrate to heparin, and in this trial there was nearly 600 patients that was randomized, and similar to the previous trials that have been done, this trial showed that the median filter lifespan was statistically increased in the citrate arm compared to the heparin arm. In addition to that, there was decreased major bleeding in the citrate arm compared to the heparin arm. So now that I've given you the evidence of why we should be using citrate for anticoagulation for CRT, let's talk about the mechanism of how citrate works. So this represents the coagulation cascade, and calcium is required for every aspect of the coagulation cascade to clot the blood. So what happens with citrate is citrate chelates free calcium. So essentially, citrate is provided prior to the hemofilter where it chelates calcium. By doing this, it prevents the activation of the calcium-dependent coagulation factors, and the anticoagulant effect is measured by the circuit ionized calcium. You can then reverse that effect by providing a systemic calcium infusion back to the patient. Importantly, just to keep in mind that the normal blood levels of citrate are approximately 0.05 millimoles per liter, and bleeding times prolonged to infinity at a citrate level of what corresponds to about 3 to 5 millimoles per liter in the blood, which then corresponds to an ionized calcium in the circuit less than 0.4 millimoles per liter. Citrate is metabolized primarily by the liver, and potentially if you have good liver function, 1 mole of citrate can be metabolized to 3 moles of bicarb. So citrate can also provide a buffer, which we'll talk about when we talk about the acid-base complications of citrate. So if you look at that therapeutic ionized calcium range for citrate, it comes from studies like this. This is one study that was an in vitro study looking at the ionized calcium and clotting time in 6 healthy volunteers. In these patients, each subject was anticoagulated with ACDA, which is one of the type of citrate formulations, in different amounts. And what you can see by this slide here is that the ideal anticoagulant effect was really less than 0.5. Most people say from various other studies between 0.25 and 0.4. That's the ideal therapeutic goal. Once you get to an ionized calcium greater than 0.5 in the circuit, there really is no point in using citrate anticoagulation because there's no real effect. So this is how citrate works. This is basically your circuit. So you can see that citrate is given right where the access attaches to the circuit prior to the blood pump. Essentially, the post-filter ionized calcium is then measured to keep that the ionized calcium within the range of less than 0.4 millimoles per liter. The calcium citrate complex then returns back to the patient, where citrate's metabolized by the liver and returns the calcium to the patient. However, since you're losing calcium citrate complexes in the effluent rate, calcium infusions provided to the patient to keep the patient's ionized calcium within normal range. Now, if you look at the different types of citrate solutions available, these are the most common citrate solutions used worldwide. You can divide them into hypertonic solutions and isotonic solutions. The hypertonic solutions are concentrated, and as you can see by the slide, have a higher sodium concentration, which may then require adjustment of your other CRT solutions in terms of the sodium level. If you look at the isotonic or dilute citrate formulations, these are more compatible with keeping the sodium within a normal range, and these are also used as replacement fluid. So not only are they used for anticoagulation, but they're used for convective clearance, so they're perfect for convective modalities in terms of anticoagulation using citrate. Now, how do you decide how much citrate to give? Well, the citrate rate to give to the patient to achieve the ionized calcium in the circuit of 0.025 to 0.4 is dependent on the blood flow and the citrate concentration of your solutions. This is a common table guideline that you can use given your citrate solution, what you can anticipate of giving or starting off this citrate rate based on the blood flow. So typically for 4% trisodium citrate, anyone use that here? For 4% trisodium citrate, essentially is 1.33 times the blood flow. For ACDA, it's about 1.5 times the blood flow. And for Reducid, it's 10 times the blood flow. And these are the amounts that are given to achieve the citrate concentration of 3 millimoles per liter in the blood. Now, thankfully, many of the CRT machines that utilize citrate today have integrated calcium and citrate pumps, so you don't have to do the mathematics calculation. Unfortunately, this is not the case in the United States. So if you want to calculate how much citrate to give, it's actually pretty straightforward math. So you take the blood flow, multiply by the citrate concentration you want to achieve, and that gives you the citrate load. You then divide the citrate load by the citrate concentration, the formula, and that basically gives you your citrate infusion rate. So let's take an example of ACDA. ACDA essentially has a citrate summary or summation between the citrate and citric acid of about 116. So if you take the blood flow of 100 milliliters per minute, which is 6 liters per hour, and you want to aim for a citrate dose of 4 milliliters per hour, then 4 millimoles per liter, that's a citrate load of 24 millimoles per hour. You then divide that by 113, which is a citrate concentration in that solution, and that gives you the citrate rate. So it's very easy in terms of calculations. What about calcium dosing? Well, the calcium dosing or starting calcium infusion rate really varies by different protocols, the calcium concentration used, and the systemic ionized calcium goals. But in general, the calcium concentration to initially start your CRT system is essentially you give a minimum of 1.7 millimoles per each liter of effluent, and there are mathematical formulas that I can give you to calculate that calcium rate, depending on your concentration of your calcium solution. If you look at monitoring, besides monitoring your routine electrolytes, for citrate, the typical monitoring is measuring the circuit ionized calcium every 6 to 12 hours to keep that, again, less than 0.4, or some institutions do 0.25 to 0.4. And then, of course, to measure other electrolytes periodically, including total calcium, because we will talk about that when we talk about citrate accumulation. So the biggest concern with giving citrate is citrate accumulation, also known as citrate toxicity. And so what happens essentially is that calcium citrate complex is not metabolized by the liver. So therefore, citrate keeps chelating calcium, which then decreases your ionized calcium in the blood. So in order to correct that, more calcium infusion is given. Calcium, of course, binds albumin, is measured as total calcium. And so, giving calcium, actually, what happens is It's basically, like I said, measured as total calcium. So your total calcium to ionized calcium ratio increases. So this is what's represented on the right side of this slide, is the actual calcium citrate gap, your total calcium to ionized calcium increasing. So that ratio increases greater than 2.5. So essentially, citrate accumulation occurs in shock states, like I mentioned before, severe lactic acidosis, or in case of the advanced liver disease. Typically, it's tolerated well in cirrhosis, as those patients usually with shock liver and transaminases in the 1,000 level. The citrate accumulation, again, is manifested by increasing metabolic acidosis. So often citrate is helpful in providing the buffer in these patients. A falling systemic ionized calcium concentration, a rising total calcium, as I already mentioned, and escalating calcium infusion requirements. So now, if you have a citrate accumulation, how do you manage it? Because this is the best or most feared complication. And by the way, if you look in the literature, the actual complication is very rare. It does not occur much more because of better citrate protocols, better understanding of citrate, better machines that can do citrate, etc. But these are the ways you can manage it. You can increase the effluent rate to remove more citrate. You can decrease the blood flow rate. That also decreases the citrate load to the patient. And you can decrease the citrate infusion rate. But of course, if you do this, then you might affect your anticoagulate therapeutic ionized calcium ranges in the blood. So you don't really want to do that one. So I just want to bring up for the last few minutes some of the concepts of citrate dose and load. So dose is the amount of citrate we want to give. It's based on the blood flow, essentially to maintain the therapeutic citrate concentration in the blood, between usually 3 to 4 millimoles per liter. Citrate load is actually the metabolic load that goes to the patient that causes the acid-base abnormalities that we are all concerned about. Now, there are protocols in the literature in patients who have anhepatic metabolism or can't metabolize citrate at all, shock protocols where essentially you can use a very low blood flow and a high citrate extraction rate and deliver citrate to most individuals, even with patients with severe lactic acidosis or transaminases in the thousands. So there are ways to get around this citrate load to the patient. So this is a table that I came up with looking at how the changes in various parameters of CRT affect your load to the patient. So essentially, if you increase your blood flow and you have a proportional increase in the citrate to keep that dose the same, that will increase the metabolic load to the patient, leading to more metabolic complications. Similarly, if you just decrease the effluent flow rate, that decreases how much citrate's removed. That will increase your metabolic load also. If you just increase the blood flow rate and keep your citrate rate the same, that increases the metabolic load to your patient. So if you understand this table, you can really mitigate any acid-base abnormalities in your patient. And there are mathematic formulas that I can give you that basically confirm these findings here. I'm all about the math. So in summary, the acid-base complications that you see with citrate are very easy to handle if you know those principles that I just went over. So for an instance, if you have citrate excess, and what I mean by that is you have metabolic conversion of citrate to bicarb resulting in excess buffer, this is manifested by metabolic alkalosis. Your total calcium to ionized calcium ratio is not elevated because citrate's metabolized. And in this situation, if you decrease the blood flow rate, then essentially you will decrease the amount of citrate load to the patient, so you get less metabolic problems. Or, of course, you can decrease the concentration of bicarb in your buffers or buffer in your CRT solutions. Citrate accumulation, you treat it the very same way. You can either stop citrate or you can decrease the blood flow rate, so you decrease the metabolic load to the patient, and you can increase the effluent rate for more extraction of citrate. And like I said, there are many successful protocols published now that allow patients who normally will show signs of citrate accumulation who can be treated this way. And finally, there are situations where citrate may not provide enough buffer for the patient, and they have a metabolic acidosis because of inadequate blood buffer supply, but not because of not because of citrate accumulation. In this situation, you will get a metabolic acidosis, but the total calcium to ionized calcium ratio will not be elevated. And for this, you can increase the blood flow rate, which will then give you more citrate and convert it to bicarb, or increase the bicarb concentrations in your solution. So in conclusion, citrate is a preferred anticoagulant for CRT. There are many studies that have now shown that. Because the development of more user-friendly citrate formulations and machines that integrate calcium and citrate formulations has become very easy to deliver citrate, and the acid base or the abnormalities you can see or consequences of citrate are very easy to handle if you understand these basic concepts. So thank you very much.
Thank you, Ashita, for a great overview. As with the previous talk, we will take questions straight after the talks. Are there any questions? Yes, Stéphane. Professor Gaudry from France.
Thank you very much for this talk. I have a question. How do you explain the increased rate of infection in the largest randomized controlled trial in this question? And my second question, is there any data on this in chronic hemodialysis? Did that increase the rate of infection?
So what he's referring to is in that randomized trial, the largest one done with 600 patients, a post hoc analysis of the data initially reported that patients with citrate seemed to have an increased risk of infection compared to patients who were treated with heparin. When that group looked again at that data, it seemed to be not secondary to the citrate, but any anticoagulation that essentially increased or filtered survival. Now, the mechanism for that, or that reason for that, is really not understood. Some thoughts are maybe more exposure to the filter. However, I do know that there's a paper coming out in the pediatric group that has not shown those results. So again, given the fact that it's post hoc analysis and observational from that, I don't think at this point we can put a lot of weight into that. As far as chronic dialysis in terms of increasing risk of infection, specifically if you're talking about citrate, it's not used as commonly in chronic dialysis, but I'm not aware of any increased risk of infection based on anticoagulant.
There's one more question, one final question.
Good evening. I would like to ask you what's your experience in patients with acute and chronic liver failure?
With liver failure?
Acute and chronic. Also.
Acute on chronic. In terms of giving citrate?
Yes.
Most of the literature now demonstrates that even in the situations of liver failure, specifically like cirrhotics, citrate is actually well tolerated. And so what we do is in those patients, we monitor probably more closely the total calcium to ionized calcium ratio and prescribe a rate of citrate or a dose that may be on the lower side. In those specific patients, you can also decrease the load of citrate to the patients by really using a much lower blood flow too, because you can achieve the same dose of anticoagulation in the circuit, but not the metabolic load to the patient. So we do use citrate very effectively in those patients. Good question.
Thank you.
Ashita, thank you very much for a comprehensive overview.
So please join me welcoming Dr. Emily C. from Australia. How to minimize dialytrauma. Floor is yours.
Thank you. I'd like to start by thanking the organisers for the opportunity to speak to you today about what's definitely become a growing area of interest in the renal replacement therapy space. I'm having similar issues. These are my disclosures. All right, so renal replacement therapy is one of the most common forms of organ support that we prescribe in the intensive care, whether it be for removal of solutes, fluid, or even toxins. Increasingly, we're recognising that how we prescribe renal replacement therapy is an important predictor of patient outcome, whether that be survival or even renal recovery. It's thought that biocompatibility of the system is crucial and is a key contributor to how patient outcomes evolve. Initiation of renal replacement therapy brings a number of changes to the bedside, including a blood circuit interface, vascular access and anticoagulation, as we've just heard. Also changes in drug pharmacokinetics with increased rates of drug removal, There are changes in plasma composition and also changes in intravascular blood volume. And so dialytrauma is a term that encompasses all of these potential and actual harmful events relating to prescription and delivery of renal replacement therapy. So several forms of dialytrauma have already been described, and as you can see, they affect essentially every organ system. For many of these, we're acutely aware of them and we actively investigate and treat them. But the second group of dialytraumas are thought to originate from the circulatory strain of renal replacement therapy itself. And much of the literature on dialytrauma has come from the chronic hemodialysis space in patients receiving intermittent hemodialysis. So what are the circulatory effects of renal replacement therapy? Well, plasma water is removed from the intravascular compartment by ultrafiltration, and that fluid that's been removed is then replaced by fluid from the interstitial compartment through vascular refilling. The rate at which fluid is replaced into the intravascular compartment is highly variable both between patients but also within patients along their clinical course. And this is particularly true in critically ill patients, especially those with sepsis. Some of the recognised determinants include fluid status, plasma oncotic pressure, and also transcapillary hydrostatic pressure, and also their endothelial function. So based on that, it's no surprise that it's a dynamic clinical situation. So when the net ultrafiltration rate, that is, the rate that fluid's removed from the patient, significantly exceeds the vascular refilling rate, intravascular volume contraction occurs. This decreases preload, stroke volume, and cardiac output, manifesting as hypotension and organ hypoperfusion. Hypoperfusion of several key organs has been well reported in the literature. Hypoperfusion of the brain leads to impaired cognition, decreased cerebral blood flow. Of the heart leads to myocardial stunning and regional wall motion abnormalities. Of the gastrointestinal system leads to decreased liver function and also endotoxinemia. And finally, hypoperfusion of the kidney actually leads to acute kidney injury, the exact thing that we're trying to treat. So it's no surprise that hypotension and hypoperfusion can induce an ischemic injury in the kidney. That's something we've known for centuries. But we always associate the ischemic injury as being that of the initial insult, whereas increasingly we're recognising that ongoing insults may continue to persistent states of acute kidney injury. So in this study of Vietnam War casualties, patients were biopsied at 3 to 4 weeks after their initial insult, and on biopsy it was seen that there were fresh areas of tubular necrosis. On review of their clinical notes, there was no obvious episodes of hypotension or other ischemia, apart from transient hypotension that occurred during their intermittent hemodialysis sessions. And this is really the first evidence that dialysis itself, especially when performed intermittently rather than continuously, may actually induce an acute kidney injury with every session. It's not surprising that patients with acute kidney injury are especially prone to circulatory variation, given they experience a loss of autoregulation, which is especially true at low mean arterial pressure. Transient hypotension can induce a loss of function compared to pre-hypotensive episode. So Chris McIntyre and his group have done really important work, which I'm now going to focus on, looking at renal perfusion during dialysis, because until now everything's really a surrogate marker. Chris and his team dialysed 29 patients in the CT perfusion and also did transthoracic echo to assess for myocardial hypoperfusion. He found that so patients were imaged before, during at 3 hours and also after hemodialysis, and he demonstrated quite consistently a decrease in renal perfusion by as much as 18.4% at 3 hours. Concerningly, renal perfusion didn't normalise to baseline at the end of treatments, only returning to 95%, suggesting that even after the insult has occurred, there is persistent abnormalities in renal blood flow. He did a comparison between different dialysate temperatures to see if that impacted the circulatory effects, and he found that in patients having standard hemodialysis, so that's 36.5 degrees, 2/3 of kidneys had any decline in perfusion, and the average perfusion decrease was as much as 21%. Conversely, patients receiving cooled dialysate of 35.5 degrees, only half of the kidneys experienced a decline, and it was less. So in the chronic intermittent dialysis literature, this finding was particularly important in terms of trying to stabilise the circulatory effects of their treatment. In terms of the myocardial function, he found that myocardial stunning occurred in 83% of patients, with no difference between the dialysate temperatures. And concerningly, the number of stunned segments correlated with decreased renal perfusion, suggesting that this truly is a multi-system, multi-organ circulatory insult. This is supported by the fact that patients without myocardial stunning were protected from decreases in renal perfusion. He found an association between the intensity of fluid removal and both the degree of decrease in renal perfusion, but also the number of stunned segments, suggesting that ultrafiltration rate is a potentially modifiable contributor to circulatory strain during dialysis. Concerningly, changes in renal perfusion as well as myocardial stunning occurred even in the absence of significant hypotension, suggesting that some of the markers by which we assess the circulation may not be sufficiently sensitive. Throughout the literature, there are numerous publications that demonstrate the impact of circulatory strain on organ perfusion, with publications looking at cerebral perfusion, also looking at cardiac perfusion and myocardial stunning, and finally gastrointestinal perfusion. So to answer the question of how to minimise dialytrauma, we need to accept that the current literature on dialytrauma is largely taken from the chronic hemodialysis setting and in patients receiving intermittent hemodialysis. There are scant studies on intermittent hemodialysis in AKI and almost no studies involving patients on CRRT. Hypothetically, patients receiving CRRT would have less circulatory strain because the intensity of therapy is reduced comparatively, but the dynamic context of critical illness makes it really challenging to fully estimate that. So we currently don't know how to minimise dialytrauma in patients receiving renal replacement therapy for acute kidney injury, but there are several potential ways that we could modify the dialysis prescription that may impact patient outcome. Several of these are the subject of active trials where we're looking at whether limiting the intensity of fluid removal by CRRT may impact renal recovery and patient survival. So there's active trials going on in Australia and also in the United States. The use of advanced hemodynamic monitoring, given the fact that hypotension in and of itself is insufficient to recognise circulatory strain. Blood volume monitoring through hematocrit devices enables an estimation of the comparative rates of net ultrafiltration and plasma refilling and may be a useful intervention in terms of guiding clinicians with the intensity of fluid removal. And finally, with Tomoko's group, she's looking at limiting or having a lower target of solute clearance in terms of whether that can impact patient survival. So bringing that all together, dialytrauma is a term that encompasses all harmful events relating to renal replacement therapy. And it originates from exposure of blood to the extracorporeal circuit, as well as everything that's involved in the circuit, like vascular access and anticoagulation. It also arises due to removal or addition of fluid and solutes. And so an example of where addition of a solute can be harmful is dialysate containing a normal sodium concentration in severely hyponatremic patients. It can also arise from unwanted removal of drugs, especially antibiotics. It's multi-organ and multifactorial, and potentially its consequences are preventable and reversible, meaning that continued research in this space is greatly important. Our current data are largely extrapolated from the chronic dialysis and intermittent hemodialysis setting, so understanding how these effects play into acute kidney injury, the intensive care environment and continuous renal replacement therapy is important. And to answer some of these questions, there's several trials that are currently ongoing to investigate novel interventions to potentially minimise dialytrauma and improve patient and kidney outcomes. Thank you.
Thank you very much, Emily, for the excellent presentations. So any questions from the floor? So it's really interesting that we don't know what is happening to the kidneys during the CRT. And is there any exploration to monitor the kidneys function or how the kidneys are doing during the CRT? If you have any information on that?
Yeah, so I think it's challenging to do any form of monitoring of kidney performance when we don't have good biomarkers and other means by which to adequately assess kidney function, especially in real time. So there's lots. I mean, using advanced hemodynamic monitoring may give an idea of how the circulation is coping with the strain of renal replacement therapy, but there's currently no good means by which to assess the kidney function specifically. A lot of the data looking at the kidney effects of renal replacement therapy are in intermittent hemodialysis, so that's a much more intensive therapy, and whether the same hypoperfusion detectable by CT scanning is detectable in continuous renal replacement therapy is unknown. And if anyone's brave enough to take a critically ill patient to the CT machine for a few hours, it would be much appreciated to answer that question. But I think we don't currently have the tools to identify this problem, and the tools that we have, like blood pressure and detecting hypotension, clearly are insufficiently sensitive. And so for the moment, I think doing what we can in our dialysis prescription to maintain the highest quality is the best sort of standard practice while we wait for some of the results of these trials.
Excellent. Thank you very much.
Thank you.
Yes, question from Boris?
Well done, Emily. That was an excellent presentation. The thing that really puzzles me about this is it's not the blood pressure, right? I mean, you know, everyone gets completely hung up about that, and we'll get predictive models to see what happens to the blood pressure. We'll do something about it. I mean, it's clearly not that.
Yeah.
So what do you think it is?
Well, it's organ perfusion, which we can't currently monitor.
So do you think it's a microcirculatory effect and shunting, or?
I think it's both macro and microcirculatory, and it probably depends on what the etiology of the AKI is. And this is the complexity with, looking at blood volume monitoring. The effect of ultrafiltration on blood volume monitoring is very different in septic patients compared to non-septic patients in terms of the endothelial function. And so it's almost any investigation has to much more tightly phenotype patients to try and get a more homogeneous population that we can interpret results. So I think in things like sepsis and major surgery and vasodilated states that it almost certainly is a combination of macro and microcirculation. But there may be other types of AKI where it's a pure macrocirculatory effect where measurements of blood pressure, lactate, other markers of organ perfusion may be sufficient.
Thank you. Yes, one more question.
Thank you for this excellent lecture, Miklos Lipchev from Uppsala, Sweden. You keep talking about blood flow and perfusion, and when I went to medical school, I was taught that the kidney would guarantee its perfusion given its given blood pressure. So do you think the autoregulation doesn't work in the kidneys during RRT?
So based on animal studies, it's suggested that in AKI, especially severe AKI, that autoregulation is dysfunctional. It's almost impossible to do in humans, but extrapolating from animal models, it's suspected that autoregulation is impacted. But you're right, that was the rule that we all learned, but in severe AKI it appears to not function as well.
Another question?
Thank you very much for the presentation. I would just have a question a bit provocative, but just for the sake of discussion. So when we think about reduction of perfusion in the kidney during CRT, as you said, it's mostly described in intermittent mode dialysis rather than continuous one. But is it that really due to the dialysis system, or maybe just the fact that the kidney is at rest during the dialysis, so it requires less perfusion, but because it has just less metabolic work to do?
Yeah, so again, I think that really touches on something that is the greatest challenge in really trying to estimate what the blood flow is, which is that in critically ill patients, even if you're taking a small amount of fluid off, you don't know in what other directions the fluid is moving. So in patients in the very early stages of sepsis, the amount of fluid that goes from the intravascular compartment to the interstitium may actually exceed what you're taking off with renal replacement therapy. So it's not a linear correlation, and you know whether you can say that that if there's less perfusion, that the kidney is resting. I think that's again something that can't be concluded in human studies, but I think it's more reflective of the state of the intravascular compartment and the direction of movement of fluid, which is dynamic across the clinical course, but early on is very unpredictable. And that's really the time that we're targeting in these trials that are looking at limiting fluid removal via ultrafiltration to better see whether we can sustain kidney perfusion and other organ perfusion.
Wonderful. Thank you,
Thank
Emily. So let's move on to the next speaker. The next speaker is Professor Marlies Ostermann from the UK. Dosing is less more. The floor is yours.
Thank you. Thank you very much for the kind introduction, and thank you for the opportunity to contribute to this important session. So in the next 15 minutes, I will explore renal replacement therapy intensity and address the question whether less is more. I have no particular conflicts related to this talk. Now, before I talk about the prescription and the dose, I want to remind everybody of our normal renal capacity. And with a GFR of 100 to 120 mils per minute in health, it means that our normal kidney capacity is about 70 kilo person would be about 85 to 100 mils per kilo per hour. So the question now is, how much do you need in severe illnesses when your kidneys are not working, and what should be the prescribed dose? Now, when we talk about dose, we are essentially referring to the amount of blood that should be cleared and benefit the patient. Now, it's difficult to really calculate the dose, but we now know that the dose correlates with the effluent, and that's essentially what we're prescribing. So there have been numerous trials in the literature comparing different doses, and I've just highlighted 3 landmark trials here, and some of the authors are in the audience here. But as you can see here, they compared 20 versus 35, 25 versus 40, or even 35 with much higher doses. Higher, but still not the normal dose in health. And all these trials showed that there was no mortality benefit, with a dose higher than 20 to 25. So based on these landmark trials, the KDIGO guideline now recommends to a dose of 20 to 25 mL per kilo per hour, given the absence of any survival benefit with higher doses. Now, I showed you the 3 landmark trials, but there are also a couple of other trials in the literature, and this prompted Professor Bellomo to undertake a systematic review of all these existing trials. And they looked at the data of 7 randomized controlled trials and essentially showed that what the 3 landmark papers are already shown, that a higher intensity, still not normal, still below the physiologic dose, but a higher intensity, greater than 20 to 25 mL per kilo per hour, did not give any mortality benefits or survival benefits, did not reduce mortality. Even when they looked at intermittent versus continuous renal replacement therapy, there was no real difference. But of concern was the fact that patients in these trials who have been randomized to the higher dose had seemed to have a significantly higher risk of still being on dialysis at 28 days. And so the authors of this systematic review concluded that in patients with severe acute kidney injury, a higher intensity renal replacement therapy, so be greater than 20 to 25 ml per kilo per hour, did not influence mortality, but could possibly delay renal recovery and leave people dialysis dependent at 28 days. Now the question is, why did this happen? And we don't really know, but it is possible that all the factors which were outlined by Dr. C earlier, dialytrauma, loss of nutrients, loss of beneficial substances, potential hemodynamic instability contributed to the delay in recovery. But then leads the question, would it even be beneficial to go to lower doses? Now, we've almost had an experiment here by the fact that in Japan, the Japanese health insurance only covers a dialysis dose of maximum 20 liters per day, which is on average 10 to 15 mL per kilo per hour. And that's a dose which people have been receiving for years in Japan. And this prompted colleagues to look at the outcome of this much lower dose of dialysis. In a multi-center retrospective review of data from 14 ICUs in Japan, the team looked at different doses of renal replacement therapy here, as shown on the slide. And they were interested in 2 things. Number 1, are these low doses actually effective? Do they correct uremia? And number 2, do they affect outcome? And before looking at the outcome on effect on uremia, I want to show you here that the number of people randomized, or not randomized, receiving these lower doses were the average patients as we see them routinely in our intensive care unit. And obviously, if you're limited to 20 liters per day, then the person with a higher weight will obviously receive a lower dose. And as you can see here, the doses of less than 10 mL per kilo per hour, patients in this group are also patients who had a significantly higher weight. The severity of illness score was a bit higher in those who, by clinician decision, had received slightly higher doses, so around 20. When they looked at the impact on uremia, and they used removal of urea and removal of creatinine in the subsequent week after starting, you can see here that doses down to 10 mL per kilo per hour led to a reduction in urea and a reduction in creatinine. And the patients who received only less than 10 mL per kilo per hour didn't really have major changes in their urea or creatinine concentration. But doses above were effective. And when they looked at outcomes, and they concentrated on mortality and duration of renal replacement therapy, patients who had received much lower doses did not have an increased mortality. So essentially, this analysis of clinical practice showed that doses down to 10 to 15 mL per kilo per hour were sufficient to control uremia without putting patients at increased risk of mortality. These were the data from Japan, and it's obviously interesting now to compare them with clinical practice data from other places. And this was done here in this analysis, where the team analyzed data from a Japanese database and compared them with data of the BEST study. Now, the BEST study was a landmark study in 2000, but it's now a little bit outdated, but it still has the data from 54 ICUs receiving renal replacement therapy up till 2001. But as I say, the data are 25 years old. But nevertheless, when you do this and then compare the outcome of these different intensities, the first thing to say is that at that time, in 2000, a lot of patients received lower doses than the current recommended dose of 20 to 25. And it wasn't just in Japan, also in Europe, in Australia, and in North America, patients received renal replacement therapy doses at significantly lower doses. When the data were compared and a multivariable analysis was conducted, interestingly, receiving renal replacement therapy in Japan was significantly associated with a mortality, with a survival benefit. So compared to patients who received doses and renal replacement therapy in other countries, patients in Japan had an advantage in this multivariable analysis. And when they focused on, again, different doses received by patients, then there was no real mortality difference. And patients receiving the lower doses did not have an increased mortality. But as I've already shown, it appeared that the patients who received dialysis in Japan at that time had a mortality benefit. So in conclusion, this very important analysis showed that receiving CRRT at around 14 mL per kilo per hour was sufficient to control uremia, and it did not have any worse outcomes compared to a dose of 20 to 25 mL, which is the currently recommended in the KDIGO guideline. So this clearly then leads to the question, is less more? And if the answer is yes, in theory, if it is yes, then that is a dose which would also have other benefits downstream. It would mean that we use less fluids at the bedside, we would have less consumables, we would require less electrolyte supplementation, there would be less costs, less waste, and possibly better outcomes. Obviously, we don't know this because these trials randomized controlled trials comparing the lower with the current recommended doses have not been done so far. But I'm pleased to inform you that 3 randomized controlled trials are currently actively recruiting. The LIMIT trial here at the top is led by Dr. Fuji, the co-chair of this session. We have a trial conducted actively recruiting in Germany, and the Wisdom trial, which will start in Canada and beyond. So in conclusion, the current guidelines, the current KDIGO guidelines recommend a dose of 20 to 25 mL per kilo because the study showed there was no survival benefit with higher doses. Systematic reviews suggest that higher doses may be associated with delayed recovery. And observationist data from Japan are very favorable, showing that doses of 10 to 15 mL per kilo per hour are as good as 20 to 25. And therefore, these trials that are currently actively recruiting are urgently needed and will hopefully give us an answer in the next few years. Thank you for your attention.
Thank you very much, Professor Ostermann. And any questions from the floor? Yes.
I have a question. Most of these trials are looking at urea clearance. And as we know, we treat CRT for many different indications besides urea clearance. We may use higher doses for acidosis, for hyperkalemia. And so I guess from my perspective is how do we handle those patients that need more of a dynamic dosing and whether these trials will really give us an answer for that, since are we looking at other measures or other solutes that are being cleared and whether we need to be doing that?
Very good question. And that's certainly something, it's not being addressed really in these trials. But if you compare it with mechanical ventilation, for instance, where we give full mechanical ventilation, and we may wean down to CPAP, and when patients are unwell again, they may be fully ventilated again. If you compare renal support with respiratory support, that's exactly what we do. We adjust the support according to the needs of the patients. That would be the next step. You're absolutely right. And it may be that a dose of 10 to 15 is too low for some people during an acute illness and may be absolutely fine later on. But that's currently not being addressed, unless you address it, Tomoko. Are you in your trial?
I don't know, our trial doesn't address this question, but we've done another observational study exploring the intensifying the early phase of the dose during the CRT session. And again, we didn't see any beneficial effects from the other doses of the CRT. So we're not sure at this stage if any tailored doses or any or one size fits all to all the patients, but definitely the patient clinical courses changes dramatically during the first several hours or 24 hours. So probably there is a room to explore how we change the doses. Thank you. Another question?
Hello, good afternoon. Just one question. Which weight would you use? Ideal body weight, actual body weight, or adjusted body weight, especially for those who are on the two extreme ends of the Gauss curve, like BMI extremely low, BMI very high? Because this is an ongoing debate within our department, so I would really appreciate your opinion.
That's a very good question. I tried to explore this and ask the authors of the previous trials so what they did, and there seemed to be some heterogeneity. What I do in the unit where I work, where we aim for 20 to 25 moles per kilo per hour, the weight we use is the weight which we also use for everything else, for the drug chart, for mechanical ventilation, and it's ideal body weight. So we use one weight and then use it for everything else, because it would be odd if you did drug dosing according to one weight, but then had, I don't know, renal replacement therapy according to something else. So that's our pragmatic approach. In the trials, the three which I showed, it was some heterogeneous practice.
Thank you.
Any other questions? So thank you very much, Professor Ostermann. Okay, so let's move on to the next speaker. The next speaker is Dr. Raghavan Murugan from the United States. AI prediction of hypertension and dialysis dosing. The floor is yours.
Good afternoon, everyone. I'd like to thank the organizers of this meeting for providing us a chance to talk about using AI and machine learning to try to predict intradialytic hypotension in critically ill patients with AKI. So in terms of the disclosure, the work I'm about to show you are all funded by the United States National Institute of Health. Other than that, I don't have any sort of a direct conflict of interest. So if you look at intradialytic hypotension, it's a common problem during RRT. And this is a study that we looked at using the ATN, acute renal failure trial cohort, that compared solute dosing. We just looked at the patients who received hemodialysis of 300 patients. And what we found was that the incidence of intradialytic hypotension was 40%. So we define interdialytic hypotension as hypotension that requires a clinical intervention. So this is not just a drop in blood pressure, but a drop in blood pressure coupled with something that the clinicians felt they needed to do to treat that blood pressure. And the interventions include initiating vasopressor, either stopping RRT or fluid removal or other interventions. And using this definition, we found a 40% incidence of interdialytic hypotension during hemodialysis. And when you look at the mortality, it was 30.5% in patients who did not have IDH compared to 44% in who did have IDH, with a significantly increased risk of death of about 66%. So we all agree that interdialytic hypotension is a big problem in critically ill patients. Now, if we look at the studies that have been used to try to predict interdialytic hypotension, there have been many studies that have been conducted primarily using retrospective data, looking at large databases, using clinically available data to predict it. And this is a meta-analysis of 8 studies over 28,000 patients. The extreme gradient boosting and deep neural network were highly predictive of interdialytic hypotension. Importantly, when you compare it with any of the sort of the clinically available tools such as the Socrates score or a perfusion index, the performance was very, very poor. So the machine learning clearly outperforms many of the clinically available tools to predict interdialytic hypotension. But an important thing to note is that these were all not done in real time. These were all after the event has actually occurred, using either the values that were available at the start of dialysis and just using electronic health record data, comorbidities, and blood pressure, and so on. So we wanted to see whether we can actually predict interdialytic hypotension in a real time before it actually occurs so that we can do something about it or we can actually treat it. So we looked at a cohort of patients in University of Pittsburgh Medical Center undergoing hemodialysis. So we took about 1,685 sessions, about 276 patients had IDH, 432 did not have IDH. We looked at all the traditionally available data, EHR data, lab, vital signs, but we also included the ICU monitor data, including the waveforms, the arterial waveforms, the pleth signals by applying machine learning to those shape of those waveforms. And we looked at a variety of features, including the moving average, slope of those data, coefficient of variation, minimum, maximum, etc. And we tried to use this data for every minute for 30 minutes before actually the event happens in hypotension, patients who developed interdialytic hypotension. So in patients who did not develop interdialytic hypotension, we randomly picked a time point corresponding to the time at which the interdialytic hypotension happened in patients who had the event compared to patients who did not have the event. And if you look at and we fitted random forest classifier, and we used more than 700 features using different data points, including when we included the waveforms, the prediction ability significantly increased. So if you look at this graph here, about 2 hours before the start of dialysis, the AUC prediction is about 0.73 here. But over a period of time, just 30 minutes before the hypotension actually occurs, the predictive value significantly goes above from 0.8 to actually close to 1, suggesting that closer the predictive ability to the event, the higher the prediction ability is. And we were able to predict it using the 2 hours before IDH with a sensitivity of with AUC of 0.73. Immediately before the IDH, it's 1. It has a 25% positive predictive value at 80% sensitivity and 0.51 positive predictive value at 50% sensitivity. So we then sort of ask the questions, can we fit this in terms of a relative score? We cannot tell the clinician an AUC. We need to actually give them a tool that the clinicians can actually act upon. So then we fitted the risk score in both in hypotensive patients and then in non-hypotensive patients, looking from the time before the actual hypotension actually occurs, and then also time since the start of dialysis. As you can see here, about 90 minutes before, the risk is subsequently lower. and then the risk remains flat in non-hypotensive patients. But then starting 90 minutes, the risk trajectory actually starts going up, suggesting that these patients are at an increased risk, to the point that at the level of just before the event, the risk score significantly goes up in hypotensive patients. Importantly, in non-hypotensive patient, clearly the risk level remains the same, suggesting that its ability to discriminate patients who develop IDH and non-IDH. When you look at this graph, again, from the time since the start of dialysis, you can see before dialysis, the risk is lower. But after dialysis gets started, the risk slightly increases, even in non-hypotensive patients. But in non-hypotensive patients, the risk remains constant, whereas in hypotensive patients, the risk significantly increases over time. So we then asked the question whether can we use it to develop a classifier, called a clinical decision support tool that can alert clinicians even before you start the dialysis session whether somebody is a high risk or not. So we then fitted a model using both baseline characteristics before the start of dialysis and also using all the clinically available tools, including the machine waveforms and other data just about before the start of dialysis to come up with a relative risk score. And you could see that when we just used the baseline relative data, the risk score was about 0.7 ROC for classifying patients between those who develop IDH versus those who won't. But when you use the dynamic features, the risk actually subsequently goes up to 0.9 and significantly discriminating patients who would develop IDH. So this suggests that using this tool, even before you start dialysis on a patient, you can have the ability to then decide whether am I going to do dialysis, or am I going to stop today and then come back and do tomorrow, whether I should pre-treat the patient with a vasopressors or may not remove fluid. All those decisions can be made upfront even before you actually start. So then we started using reinforcement learning to try and understand the risk on the predictive aspect of hypotension. So here, for those of you who are new to reinforcement learning, basically an intelligent agent, such as a human or machine learning, interacts with an environment, which is a physical system, and it interacts by doing an action. And the action causes a perturbation in the system, which then changes the state of that system. If the change in state is favorable, the agent gets a reward. If it is unfavorable, they get a penalty. So the reinforcement learning model actually learns based on trial and error whether I should do this or whether I should not do this. So we fitted this using for patients undergoing hemodialysis, and we stepped up the model every 15 minutes for 14 steps per session. And these are sort of the possible clinical actions that the agent can do. No action, don't do anything, increase or decrease the ultrafiltration rate, administer mannitol, or maybe start or increase the vasopressor. So we ran about 25,000 simulations using Q-learning, and this is the overall simulation data. And then when we compared it to an in silico clinical trial, what the machine learning actually did when compared to the actual clinicians, you could see that the RL agent in simulations reduced the rate of IDH by 5.5%. Whereas in clinicians, compared to actually what the clinicians did, taking care of patients, the incidence was 15%. The fluid goals was met in 95% using the RL agent, whereas in the clinician, it was met only 64%, meaning that if you decide before the start of session that I'm going to take 2 liters off, the agent was trying to accomplish that goal of what the clinician said compared to what the clinician actually did. However, one important thing to note is that the RL agent did a lot more interventions very, very aggressively. So you could see here, it increased the ultrafiltration rate 2.2 times compared to the clinicians. It decreased the ultrafiltration rate about 0.7 times. It gave a lot more fluids to those patients, and it also changed the vasopressor dosing about 28 times. Suggesting that if you're going to prevent this, then there's a lot of active engagement that is needed to prevent actually the events from happening. So what we then said was, this is using deep learning technique, using the actual data. Then we also wanted to fit a model using what is called as model predictive control. Model predictive control is actually the industry standard for many of the things that are currently out there. It's an engineering standard to model any process, quality control, etc. And it's been used in autonomous cars and so on. So in fact, it's actually model predictive control is actually used in the current closed-loop glucose monitoring systems, where it continuously monitors the glucose and gives an insulin shot based on the level of the glucose. That's all based on the MPC. So we then wanted to use an MPC model to try and see whether we can actually control the dialysis and the intervention. So here, you can build in the cost function and also the constraints associated with doing it. And so what we found was that we fitted using a Wien-Kessel model of vascular resistance using the cardiovascular system, and we ran several simulations using the MPC model. And what we found was that in these simulations, we found using about 277 dialysis sessions involving 20,000 simulations, the system was able to control the ultrafiltration rate to regulate the MAP, mean arterial pressure, in these patients. And MPC achieved a slightly higher mean MAP of about 2.5 millimeters, significantly increased the fluid removal up to 44% compared to what the clinicians did. And frequently, in the simulations, we were able to remove up to about 6 liters, which is 6,000 mLs maximum. So what we are doing next, so these are all some of the early work that we are trying to do to try and develop a system where the system itself can handle without the intervention of any of the clinicians. So you could do it in several ways. You could have an alerting system for the clinicians who can then sort of have the opportunity to override. And even better would be to completely take away from the clinicians, where the dialysis machine, patient monitor, talks to each other, and there is an intelligent system, a closed-loop system that is controlling the fluid removal rate and the dialysis metric here. So this is an integrated system, using both the MPC and also the reinforcement learning model to develop eventually what we want to go is a complete closed-loop RRT system. Furthermore, we also know that we wanted to see whether we can actually predict the adequacy of dialysis clearance in these patients. So we actually fitted a model, a volume model, and also a BUN model, where in the volume model, there's a vascular and an extravascular space, and fluid is removed during dialysis, and urine output, and fluids are given through IV fluids and oral intake. And then there is a BUN generation model, where the BUN is generated in the liver, moves into rapidly equilibrates with the vascular, and then the extravascular state, and then it's removed by dialysis. We ran several simulations, and we were able to compare what actually the model predicted compared to what the actual dialysis data from ICU patients were. And you can see using this RMSE, which is root mean square error, the lower is better. And you could see that 0.9 was very, 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 very close compared to what actually the model said the B1 concentration would be after the dialysis compared to what it was actually. So these are two patients. We did more simulation about 7 patients. These are 2 patients here. You can see that the B1 data is actually given in black dots. And then the model data is shown in the lines. And the model is actually spot on in predicting what their concentration of BUN would be, and also the volume that would be removed, and so on. So I'd like to, and these are some of the early work. So I'd like to conclude by saying that real-time machine prediction models can be used to predict development of intradialytic hypotension up to 30 minutes, even before you actually start, which gives us plenty of time to make a decision on whether I should dialyze this patient or not dialyze this patient, whether I should give them fluid, increase the vasopressor. All those decisions could be made. And machine learning can also be used to sort of decide the optimal interventions for preventing and treating IDH. Currently, we don't know what to do when hypotension occurs. We give fluid, we give mannitol, we give albumin. There are some patients, albumin might be better than giving fluids. Or in some patients, it might be better to stop the dialysis and then come back the next day to do it. So all those things could be done. Furthermore, in order to develop a closed-loop system, we need to be able to predict dialysis adequacy appropriately. So we can now do that. And so eventually ML can be used to develop a fully automated, holistic closed-loop dialysis system that would fully control the rate, taking it out of the busy clinician's hand who could focus on actually other things. But that would require a strong partnership between the industry and the academics and the hospital administration and so on. Thank you very much. Oh, I'd like to acknowledge my collaborators.
Thank you very much, Dr. Murugan. Are any questions from the floor? A lot of inspiring figures in the presentation, but I remember you mentioned that when you use machine learning algorithm during the dialysis, then the patient needs to be receive more interventions like vasopressors and fluid changes or something like that. And so does it mean that nurses, bedside nurses, were so busy when the machine learning was used? Is that correct?
Yeah, so these are all not done in real patients. So this is simulation using the patient data, but simulations done by the reinforcement learning intelligent agent that did it. So what is it telling is that if we really want to go after it, we need to be very aggressive in preventing it in the first place. So it tried to prevent the intradialytic, because that was the reward function, is to prevent intradialytic hypotension. But it also, one of the reward function is maximal amount of fluid removal. So how do you balance that? Right, so the model said, okay, you want to remove fluid and you want to maintain the mean arterial pressure. I'm going to give more vasopressors. I'm going to give more albumin and be more aggressive about managing those interventions to prevent hypotension from actually happening. Now, whether that really works in the clinical side, that needs to be tested prospectively tested. But just to give you an idea of how much work is involved in this, because think of this is like the same as driving a car. We cannot just set us sitting in the car and not doing anything, right? So we need to be able to drive through the nuances of it. And the autonomous systems can do that. And that's exactly what we are trying to do it. But taking it out of the clinician's hands, because we're very, very busy and they don't have the bandwidth to be able to do all these things.
Excellent. Thank you very much. Any questions from the floor? Okay, thank you very much, Dr. Murugan.
Thank you.
Okay, so sorry for being late here. I had some problems with a suicidal cow in front of the train, so I was late here. But I'm very happy to announce the next speaker, Professor Patrick Honoré. He is from the university. He is a professor at the University of Brussels and working now at the Brookman Hospital University. And he will talk today about antibiotic and antifungal dosing during renal replacement therapy.
Okay, thank you so much, Melanie, for this very kind introduction. Thank you also for the kind invitation from the organizing committee. So my task in the next 15 minutes will be to, see what is the importance of having an adjust dose of antibiotics to your patient, even under CRT. Antibiotics remain the mainstay in septic shock. Okay. So we go through some 4 rules that we will try to remember about antibiotics and antifungal removal during CRT. What about beta-lactams? What to do with vancomycin? The case of amikacin and the other. What is happening with fluconazole? Summary table about antibiotic in CRT. Summary table also about antifungal in CRT. Because if you are in the middle of the night, of the weekend, and you have to go through a Bible like this to find out the right dose for your patient, it might be that your patient is already dead, which is somewhat, we don't want it. All right. Some conclusion. Right, so 4 rules. First rule, molecular weight. As you can see here, this is not a big deal because most of the antibiotics we use in the ICU are very small molecule. The only issue is vancomycin. If you wanted to only use CVVHD, then you may get some trouble, in fact, by not removing, which is maybe a good thing, but if you have a CRT device including convection, then you will remove a lot of vancomycin, like I will show you. Second rule, protein binding. So the binding to albumin, but not only albumin, we know that cirrhotic patients have a lot of other carriers that can take place instead of albumin. And we know that when the binding is above 0.6, like you see here, there are only a few antibiotics that will be not removed by the system. Most of them are easily removed because not bind. Okay. Ooh, volume of distribution. So we know that volunteers have a pretty low volume of distribution. Sounds logical. The ICU patient have somewhat more, almost double. Ooh. And ICU patient plus CKRT 3 times. So something that's going to change the rule for sure. Okay. Now, there is a very simple rule for volume of distribution, which is whenever it's above 1 liter per kilo, it's a lipophilic drug. Huge volume of distribution, very difficult to remove by CRT device. You would need some other device, but it's not the theme of my talk. So, hydrophilic means very low volume of distribution. You see, below 1 liter per kilo. And so for penicillin, 0.2, 0.3, cephalosporin, 0.1, 0.3, glycopeptide like vancomycin, 0.1, 0.3, aminoside, also very low. And then on the other side, lipophilic, rifampicin, 1 liter, metronidazole, 0.8, quinolone, 0.8 to 3, and then linezolid is quite of an exception because it's a lipophilic drug, truly, and its volume of distribution is very low. It's a bit like paraquat, very low volume of distribution, but you cannot remove it by CRT. You need to remove it by hemoperfusion. It's another story, never mind. So we keep this in mind. And now we go for the sieving coefficient. Okay, and we see that above 50% of sieving coefficient, you know, 0, nothing is passing through. It's a semi-permeable membrane. 1, everything is passing through. Okay, so you see, cefotaxime, amikacin, imipenem, ceftazidime, metronidazole, piperacillin, 80%. Ooh. In 1 day. And amikacin is 100% plus the absorption that's going to be 25% on top. That's a lot. Gosh, only these 4 are not really removed because the sieving coefficient is below 50%. Now, a few words. Beta-lactams, we know that we use a lot, at least in my unit, piperacillin tazobactam. which is a very bad antibiotics, I have to say. Very poor penetration, tissue penetration, especially in the alveolar space. So for nosocomial pneumonia, not that good for VAP. Never mind. And it's a time-dependent antibiotics. And the removal is very good, sorry to say this, during CKRT, about 85% in one day. Sorry to say this. Loading dose, that's the most important thing. Remember this. Loading dose, every time, everyone. The one with CRT, the one with intermittent hemodialysis, the one with no renal function has to get the proper normal loading dose from everyone, okay? Do never forget this. Of course, after you have to slow down. But the initial dose has to be the same for everyone. Do never forget this, okay? Most important part of my talk. Now you can go to sleep. No, sorry. All right, so maintenance infusion, we have the chance now that we have for beta-lactams quite a few possibility to use infusion, and that is better because it's time-dependent antibiotics, and we need to be about 4 to 5 times above the MIC. And several studies have shown that in the Yvoir trial that Marlies was speaking about, that we did a sub-study, and we showed that we had an underdosing of beta-lactam in the patient receiving bolus instead of infusion of 80%. We haven't correlated this yet to mortality, but this should be important because back in 2003, when we decided to do the Yvoir trial, PKPD was not well known. So the both group, 35, 70 ml per kilo, received the same dose of antibiotics. As a consequence, for the majority of the antibiotics, the control group received half of the antibiotic of the treated group, and the mortality was the same. Who knows? Okay. Right. Now, what about vancomycin? So again, poor tissue penetration. Oh, we should use oh gosh. Right, so new loading dose of 35 milligram per kilo in 4 hours. Whatever the patient is. No kidney function or CRT intermittent, the same dose, loading dose, please. And then we follow by 30 milligram in infusion according to the trough value. Very effective elimination, almost 90%. And if we have a buck with an MIC of 1.5 milligram per liter, you need to go for a trough of 25, 30. That means that you would go for a higher dose. Do never go over 4 grams. Then after 10 days, you have 95% of getting AKI, okay? Right. We know also for intermittent, it's 25, somewhat less than for continuous. Now, amikacin, it's a concentration peak-dependent antibiotics, obviously. I'm seeing even in my, not unit, but hospital, that people are giving 500 milligram amikacin because they are scared about the kidney failure. Never do this. You have all the side effects, and the patient will not get better. My God. Medication in the ICU are always given in milligram per kilo of some sort of unit. So why still I'm seeing people with 1,000 milligram? you have a big chap, 150 kilo, giving this dose, will have nephrotoxicity, but he will get dead. What a pity. So, recent data are suggesting 30-35 milligram per kilo in MDR as well. And toxicity is more related to amikacin exposure time rather than peak intensity. And less if once daily. And I'm seeing in the ward all the time people with endocarditis receiving gentamicin 3 times a day, underscoring below the MIC, but a higher toxicity. Crazy, gosh. My God. Now I will skip this. So antifungal, most of them are unaffected by CRT because they have an extremely high protein binding, high volume of distribution, as I show you, lipophilicity, and mainly hepatic metabolism. But in the real life, in the ICU, sometimes it's different because we know comorbidity can alter the pharmacological profile. Drug distribution can be influenced by hemodynamic alteration with hepatic and renal impairment. And hypoalbuminemia obviously can reduce the percentage of bound antifungal. And so there is one exception, fluconazole. Fluconazole normally is being reabsorbed 80% by the proximal tubule. If you have CRT, fluconazole is flowing like this into the urine, not the urine, but the CVS system, and you need to put a lot of dosage to get above the MIC, which is about 600 milligram BD. Yes, you heard me. 600 milligram BD. Shown by Jason Roberts from Australia and some other. And so this is very crucial. And now I'm going to the final slide. Okay, so the table for antibiotics. Amikacin, I said 35 milligram per kilo, then TDM. Piperacillin, we have a loading dose and then the infusion. Vancomycin, 35 milligram over 4 hours. And then colistin 9 million and 4.5 million 3 times a day. And gentamicin 10 milligrams, a loading dose, and 7 milligram per kilo once a day for endocarditis. Okay. Now I spend this one. So for antifungal, fluconazole, you need to give 600 milligrams BD, but you have to keep an eye on the liver, to keep an eye on the brain, to keep an eye on the QT interval. Okay. And it will gain some absorption, so you need to give more. Caspofungin, no relationship with the CRT, but if you have a BMI of 40, be prepared. You need to give 140 milligrams per day to be okay. Right, conclusion. General rules of drug dosing during CRT cannot be derived from intermittent and modality stable. Most of the classical antimicrobial in ICU are easily removed by CRT. For time-dependent antibiotic, use infusion, and do never forget the loading dose, whatever the condition of the patient is. Good. For peak-dependent antibiotic, loading dose are crucial as well. Most antifungals do not need adaptation during CRT. Fluconazole is a special case, as I show you. Knowledge of MIC is always extremely important, and TDM is mandatory as a point-of-care resources. And absorption is something for the future. Thank you so much for your kind attention.
Thank you, Patrick, for this wonderful talk. Any questions from the audience? So I would like to start. I didn't see it on the table, but I guess you mentioned it. But for the Tazobactam, do you recommend to give it continuously during continuous renal replacement therapy, or should we give a bolus after the procedure?
Now, that's a very good question, Melanie. Indeed, you need to give first a loading dose. It's like for vancomycin. You need to be, at that time, about 5 to 6 times above the MIC for pib-tazobactam. And then you start the infusion immediately. So that's a very good point. Not start the infusion without giving the loading dose. Under no condition. Thank you.
Any other questions? It's too complicated, this topic. Okay, so thank you so much.
Okay, so let's move on to the next speaker. Next speaker is Dr. Michaël Casaer from Belgium. And his talk is about, should we care about micronutrients? The floor is yours.
Thank you very much for the introduction. Thank you to the Congress organization for having me here. Apologies, I will have less answers than Patrick and more questions, but I hope I will shed some light on some aspects of this topic. So I'm Michaël Casaer from Leuven. I have no conflict to declare. Just a warning that sometimes I can be a bit critical on the evidence we have regarding nutrition in the ICU, but I don't want to make you doubt that, of course, nutrition is crucial on the pathway from the initial insult to someone walking out of your ICU at some point, and at a certain given dose. Dr. Bellomo here and I wrote quite a while ago a paper where we tried to make a wake-up call for the risk for missed micronutrient deficiencies in the ICU due to the therapies we give, and among them you see on top of the list renal replacement therapy, but also parenteral nutrition not containing carnitine or glutamine, diuretics making us lose the water-soluble vitamins and so on. And then also the disease, as you can see here, the GI losses, fistulae, bile losses, renal failure, liver failure, large wounds like in the burn patients, making them lose lots of small molecules. And also the condition pre-ICU, even the absence of sunlight may contribute to having less vitamin D. And all these may contribute to critically or maybe relatively low levels and availability in the cells of selenium, vitamin C, vitamin E, vitamin D, iron, folate, vitamin B12, zinc, thiamine, and in the end of my talk we come back to carnitine. And all of them contribute to normal cellular functioning, but of course this is physiology, this is not clinical evidence, and may contribute to some of these unexplained aspects of the phenotype of prolonged critical illness, such as wounds that don't heal, bizarre encephalopathies, low cardiac output going on for weeks. We don't know, skin tears, many of these really sad things. Is this happening in your ICU? Well, in fact, I don't know, and you don't know neither, I guess. It depends on the patients you admit. It depends on how you feed them. It depends on how you manage micronutrients. And now already quite a while ago, with the FRAM section and many experts who have many decades and more of experience than myself, we put together a questionnaire on asking colleagues, some of them, I guess, here in the room, so thanks a lot for participating, how you manage micronutrients in your ICU. We had people responding from Europe and all over the world, so thanks again for this. This is really crucial, I think, to start working. The first thing we noticed is that indeed the way we feed has changed since the year 2000, I think. Most of the physicians no longer try to achieve full enteral or parenteral nutrition in the first days. You see how gradually patients achieve these goals. And also the initiation of micronutrients separately starts only gradually over the week. And this may, so many questions, not much answers, expose patients to potential deficiencies. Because before, when we started early with parenteral nutrition and so on, we gave them micronutrients with them, so everybody had them. And now we have this feeding-free area, which may be a risk, particularly in patients with increased losses, such as renal replacement therapy. Also because of what you give with full enteral nutrition comes close, as you can see, or above the daily requirements as defined by bodies of scientists, but this is much lower than what you would give in your parenteral preparation, so it's still not much. And so our participants in our questionnaire, many of them admitted not having a protocol for micronutrient administration. And of course, you have a selection bias of people focused on nutrition, so I guess it's even lower. Half of the protocols did take into account protecting vitamins from daylight, incompatibilities, and also a built-in system to avoid omission of the micronutrients. And half of the physicians never give additional doses of micronutrients on top of full enteral nutrition, which is maybe surprising in the context of, for example, renal replacement therapy or large wounds. Because indeed, as Tom Ziegler and Dr. Gundogan showed in a recent study based on repeated measurements in patients who were already 2 weeks in the ICU, as you all may expect, renal replacement therapy does provoke lower levels of water-soluble micronutrients. It's a quite complex paper, but anyway, it is down and it goes even more down if you start renal replacement therapy. So how could a protocol look like? Of course, with lack of evidence, it's very difficult to give any suggestions, but I try to do anyway. I guess the more a micronutrient is related to potential clinical complications, the more it might be wise to put it early in your protocol, particularly if it's water-soluble. And the more it may be present as a contaminant or has been reported to have toxic side effects, the more you might be reluctant to give it, like manganese or copper or so, this kind of stuff. The other decision to make in consultation with your nurses, I guess, is whether you give a slow bolus, as we did for many decades, just slow boluses of micronutrients, not too fast, because sometimes you can see bizarre reactions and timing, among others, which is easy, stable. You have no time for interaction between vitamins if it's only in solution for 15 minutes, and which also protects them from the daylight, because the sunlight can inactivate some of these micronutrients if you have them hang around for a long time. But on the other hand, boluses, particularly in the context of renal replacement therapy, may be associated with more of your drug being lost straight away due to the high plasma concentrations. All just physiological considerations. We give a slow infusion over the night to avoid the daylight. And how should you monitor what you achieve with your therapy? Well, in the ESPEN micronutrient guidelines, we've been a bit over-enthusiastic in promoting, measuring all this stuff, while in the end, we don't really know what is better. But the idea of some of the experts was, let's encourage them that at least we'll have some data. Well, as you can see, some of us measure a lot. On the left side, daily measurement of all this stuff should be very rich. Hospitals, maybe in Switzerland. Some of them more than weekly, some weekly, and 70% don't measure at all. And I'm also in the 70%. We very rarely measure micronutrients unless we think that there may be a case report upcoming, then of course we do. That is a nice study by Olivier Pantin and Mette Berger, who over the years increased the doses of micronutrients given to patients with vast burn injury and gradually achieved the normal plasma concentrations with these increasing doses. Is this good? Of course, we don't know, but at least it's an interesting way to analyze what you're doing. So I think they have to be congratulated for this long-term work, which resulted in finally adequate doses based on the plasma concentration. But maybe we should rather look at clinical presentation and go back to data, going back to even before the first RCT was conducted, like the studies on vitamin C by a British Navy surgeon, and look for all these kind of presentations in our patients. Not easy, of course. Again, Mette Berger gave the good example by presenting this case report of a patient with copper, selenium, and carnitine deficiency, and then some clinical symptoms related to it, potentially related to it. We need this kind of data while awaiting better data, at least to know whether we should worry about these things or not. And here, with a group of experts, with the FRAM section, we made a list of all kinds of clinical signs that clinicians might be looking at. And if you look at the right side, you see that most of the clinicians admit that, in fact, they don't look at these because most of them are reported to be controlled only in less than 10%. Hair loss, skin tears, all very difficult things to identify, osteoporosis in the ICU. But what do our patients need? Independent of whether the fact that they are yes or no on renal replacement therapy. Should we complement, just giving what normal intake should be? Should we replete, assuming that they lost a lot? Should we supplement bringing them higher for some reason or another, or should we give pharmaconutrition? I think last question I can say, no, don't give pharmaconutrition for the time being, unless very new data comes up. Now comes the boring part, all negative Kaplan-Meier, so I'll be fast, but just to convince those of you who might think that we should give higher doses of any micronutrient early in critical illness, for those that have been promoted for a long while and that have been also given in many centers for a long while, the answer is no. So vitamin C, 1 in 5 respondents said they give it as an additional supplement. We also do in Leuven at a low dose. I think we can stop doing it. The data, despite all the physiological and observational data in favor, the clinical evidence is clear based on the La Montagne study. We should not do this. No high dose of vitamin C. Vitamin D, we had a hope-giving signal by Karen Amrine in a negative study where the patients that were potentially most deficient might have benefited of vitamin D supplements, very small subgroups, not reproduced in a larger study, so I would say don't do it. Vitamin B12, a pioneer study, interesting, but hypothesis generating, showing that it might have an impact on vasopressor. So someone looking for a new study for your PhD, consider this, not yet done yet. So, and we have to do this, I think. We have to check all these things bit by bit to give answers, and for the time being, don't do it at home, I think. Selenium, another one that many of us were convinced that we knew based on physiology we had to give it. Very nice homogeneous population. Very often nutrition trials are criticized for some reason for being heterogeneous, but then patients in the ICU are also heterogeneous and they all receive nutrition therapy. Anyway, this was homogeneous, a nice model of cardiac surgery patients that were likely to benefit from selenium as it is a pro-inflammatory insult. They didn't. I'm almost ready with my boring Kaplan-Meiers. And then some of us said, yeah, of course, they don't work alone, they work together, you have to give them together. People even raise this comment still today, but luckily Darren Hyland, who checked a lot of the things we believed in, showed that it doesn't work. A nice combination of several micronutrients and high doses had no effect. And just for a reminder, for those who were born later than myself, glutamine even had a negative effect, so don't do it neither. So perhaps we should switch from these early micronutrient bombardments. I think this is Stalingrad on the left side, with many cannons simultaneously trying to reach a target and have some effect. Maybe we should go for a sniper approach, try to identify some patients in prolonged critical illness that may benefit from some interventions, which of course is even more difficult and will take 2 PhD eras to have something achieved. And just as one example, I've chosen carnitine because I like carnitine. I think it's an intriguing molecule. It's very small, so it's easily lost in your renal replacement therapy. I'm not an expert of renal replacement therapy, but I guess it is the case. It's very interesting. We all have it. Only our friend Tenebrio Molitor, who you see in the picture here, doesn't have it. And the poor guy, if you starve him, he dies fat. Now, first of all, don't start starving the Tenebrio Molitor. It's a mean thing to do, but very bizarre. They starve while still being fat because they cannot burn their own lipids because they don't have carnitine, showing that carnitine really has a role. We have carnitine. And so, yeah, carnitine is, as you all know from the textbooks, part of the carnitine palmitoyl shuttle. So for all longer free fatty acids, it's essential for transporting free fatty acids into the mitochondria and having them burned. So, of course, part of our crucial energy management in the cells. And much more, by the way. They also buffer a lot of metabolites. And we make them ourselves, so there's no problem, you would say, but we need some amino acids to make them. We need kidneys and livers that are functioning. We need vitamin C. We need iron. Many things that some ICU patients might be lacking. So there might be a risk of making less of it, and there is certainly a risk of losing more of it, particularly in patients with renal replacement therapy. The data is very limited. Our colleagues, nephrologists, cardiologists, oncologists have some small studies with some indirect positive results, like some impact on lipid profiles, which is logic, of course, because it might contribute to burning lipids, and on fatigue, as it's important for muscle and energy, and maybe even on preventing atrial fibrillation. Small data outside of the ICU. Acute interventions in the ICU, as far as I know, there is one study, the RACE study, not many patients, but several publications torn out of it, so congratulations anyway for this. where perhaps there may have been a survival benefit, but the data is very limited in numbers, as you can see, 31 patients. Interventions in chronic critical illness, there are none. And that might be something that we could address in the future, as I might convince you. Observational data in the acute phase. In the Albion study, some information that perhaps lower acetylcoenzyme A levels are in fact beneficial. And then in chronic patients, that renal replacement therapy might be associated, depending on how you measure them, where the cutoff is, with some increased levels of patients, 100% of patients in the pediatric population, renal replacement therapy after 3 weeks being deficient. And these deficiencies so may be important and may occur due to, as I said, renal failure, liver failure, cirrhosis, renal replacement therapy, low protein intake, valproate being an inhibitor, and also parenteral nutrition not containing it. And here again, Mette Berger and others who pointed out that this might be very important because it might hamper the normal triglyceride management because we need to burn the glycerides, ketogenesis because it helps the free fatty acids to go into the mitochondria, may cause cardiac failure because the heart needs a lot of energy, muscle weakness, and so on. Even maybe explaining some of the refeeding things that we see. So we wondered, does this happen or not? Because the number of studies is really poor. So thanks to some funding we obtained from the national research body and also from our university, with Jan Gunst and Lisa Larouche and our doctoral thesis student Caroline Lauwers, we went back to the patients staying prolonged in the ICU, 1,600 patients on day 6, and did liquid chromatography tandem mass spectrometry to measure the levels of this free carnitine and associated them with outcome and also looked at the impact on the intervention. It's all still very preliminary data, but with thanks to my co-investigators for allowing me to show it here. I give you just already a clue to come back next year, I hope, and give you more details. Always the way it works. And so carnitine deficiency in these patients, 6 days in the ICU, occurred in 15% of patients. So it's not something very exotic. It does happen. And it was associated with high serum triglyceride levels. But in fact, I was surprised to see at day 6 that we don't have so many patients with this problem of high triglycerides. I think, therefore, you need to be even further in the ICU stay. And also with muscle weakness, as some of you may know, in the panic study, we did the MSA sum score in 600 patients, and there was close relation, and with delayed recovery and increased mortality. Of course, all association and all still to be further analyzed. And one thing is sure, and here we come back to the topic of the talk, of course, renal replacement therapy was the major risk factor. But don't start giving carnitine today because you are looking for cutoffs, and in fact going a bit higher in the range, just as Wernerman showed 20 years ago for glutamine. If you go a bit higher, you have again an association with increased mortality and morbidity. So don't start giving it at home today, more work to do. If you would like to read more about micronutrients, there's this very nice paper on the direction of Angelique Deman that we made with our FREM section group, pointing out what we know today and what might be complications and might be risk factors for micronutrients. And renal replacement therapy comes back many times, so take some time to read. It takes some time because it's many pages. So, to conclude, should we give this to all of our patients? Maybe that's the most easy thing to do, just give the basic supplementation until we know more, but still there might be some toxicity. Maybe someone should do a really huge mega RCT, just giving it to 10,000 patients because many other things will be more important and these complications are rare. And so I think it's difficult, as we wrote 7 years ago, difficult to predict and to detect who is having these deficiencies, if anyone has them at all at the clinical relevant level. They might explain some of these sad patterns of phenotype of prolonged critical illness, but we don't know. A early high dose is certainly not helpful, so I would not do this based on the evidence that we do have thanks to people who did check this. And providing the basic requirements until further order might be wise, but we don't know. And renal replacement therapy patients might certainly deserve your special attention, and I guess you're all focused on renal replacement therapy, so they'll have this attention. Thank you for listening. I hope I stayed within time because I didn't see the time. Oh no, I went over, sorry. And I thank the Congress organization for giving some attention to this important topic. Thanks.
Well, thank you very much for the excellent presentation. So any questions for yes?
Great talk.
Thank you.
So we automatically assume that low levels means there's a deficiency, right? But how do you know that the body is not downregulating these things during acute illness? And we've learned from many trials, like, you know, giving them doesn't improve the outcomes. So do you think that we need to do first large-scale observational studies linking some of these levels with strong clinical outcomes before we're doing, at least trying to understand which patient would benefit from supplementation versus not?
Yeah, I really think that we should avoid, in our enthusiasm, skipping steps. So indeed, first, knowing how common the condition is and what are the potential risk factors to address the potential patients benefiting, then associating observational and clinical outcomes with different levels, and particularly, as we've seen with glutamine, if you see that going a bit higher is also associated with worse outcome, then be even more careful just drawing it on the patients. And then maybe also we might consider more often to do animal experiments, even though animals are never the perfect surrogate. It may help in some conditions, increasing our understanding what it does at an organ level. And for some studies, we kind of skip this, and then doing an RCT. And I personally think that once you have your focused population, then just include them all and make good predefined subgroups to see whether some patients benefit more than others. And very often you'll see that those that we think will benefit more, like high-risk patients, in the end benefit even less than the others. So yeah, I think it's a stepwise approach we have to take, and certainly not start from measuring and correcting. Thanks. Very good point.
My question, in patients with at high risk of refeeding syndrome under CRT, it's very difficult to diagnose and recognize. The question, do you think you need more loading dose of thiamine in this patient?
Yeah. Well, so the true refeeding syndrome, because I think what we often see in the ICU, hypophosphatemia associated with worse outcome in patients receiving more food, is very interesting. It might be, I'll address this tomorrow, a ready to feed or unready to feed monitor. Also Arthur van Zanten and Gordon Doig did quite some nice work on this. But so this is just hypophosphatemia reflecting maybe some kind of an unreadiness for feeding, not refeeding syndrome. Now if you mean really someone who is at high risk of refeeding based on classical concept of post-starvation, prisoners of war, whatever, then logically, yeah, I think it is considered good clinical practice to provide people thiamine. Maybe if you can, I know nothing about renal replacement therapy, but if you can, maybe you can just postpone the renal replacement therapy slightly to first correct your phosphate and stuff and see what happens, and then thereafter further complicated by doing renal replacement therapy. But else, I guess that today, even legally, you're supposed to give thiamine if a patient really has a refeeding syndrome in the emergency department. And if you know that you're giving a therapy that will provoke a loss, I guess you can be better generous. Voila. That's not a very clear answer, but and for the, in general, very simple thing, also not evidence-based, but while we know more about this refeeding in the ICU, increasing slowly is a safe and simple way to avoid many problems for the food dose, I guess.
Hi.
Thank you very much.
Hi. There is any evidence about the use of creatine in these patients?
Creatinine as a food, like people doing fitness eat. I mean, taking creatinine as a
by feeding.
Yeah, I think that given also the additional secondary analyses of the glutamine trials showing that in the end probably it was not the glutamine but just the amino acid dose per se that killed the patients, I wouldn't do any experiments with giving any kind of protein lookalike in isolated doses to patients unless really supported by trials. But I wouldn't do it. And I think also people doing fitness would better not do it, but that's beyond my field of competence.
Thank you very much. So I think it's time to move to the next speaker. Thank you.
So I'm very happy to introduce the next speaker, Professor Rinaldo Bellomo from Australia. He is actually an ICU expert, an AKI expert, a research expert, and I'm very happy to learn something from you today about the different RT techniques.
Yeah, but I don't go to the gym or take creatinine, so I don't know what to say. Okay, cool. Cardiac output during renal replacement therapy. You all think cardiac output is an important physiological variable. Well, we don't systematically measure it. Typically, people measure blood pressure. They make inferences about cardiac output and stability by looking at blood pressure. And the therapy, both chronically and acutely, is sometimes stopped because the blood pressure is coming down, but there is no response to cardiac output because it is not measured. So we decided we wanted to look at this, and the first thing we asked ourselves, of course, what do we know about cardiac output during renal replacement therapy? And so we did a systematic review. We identified 48 studies, and we asked the question about how many of these studies provide continuous cardiac output information. And it turns out that for CRT, none. And for IHD, this is chronic renal failure patients are included as well, 3. So for a very limited number of data sets. So we got very limited information about what happens to the cardiac output continuously when people receive renal replacement therapy acutely or chronically. Oh, there you go. When people have reported measurements from baseline to the minimum cardiac output measured during their therapy, you can see that there is clearly a significant decrease in cardiac output during these therapies, which suggests that this is a real event and that a degree of potentially inadequate oxygen delivery happens during these therapies, but we do not measure it. And when people report what happens to the blood pressure during a decrease in cardiac output, for patients with a severe decrease in cardiac output, greater than 30%, there is almost no blood pressure signal in about 2/3 or more of the patients. So the blood pressure is a very poor surrogate of cardiac output decreases in people receiving renal replacement therapy. When people have that information, we can also report that there is a relationship between the fall in cardiac output and the degree of ultrafiltration, and that's not a surprise. And that will be expected. There is a degree of hypovolemia, but it might be more interesting to note that there is also a significant decrease in cardiac output, what appears to be a change in systemic vascular resistance, suggesting that in these patients where information is available, there is a combination potentially of vasodilatation at the same time as hypovolemia. So in conclusion, we found that there is a significant decrease in cardiac output in a review of the literature, correlates weakly with potential surrogates of cardiac output, and there may be specific mechanisms that cause it, and we need more information. So how can we get continuous cardiac output in people receiving renal replacement therapy? There is technology that can be applied. This is the ClearSight technology. We use this pulse contour analysis, and it's been approved by the FDA. It uses the volume clamp method and allows multiple pressures to be applied dynamically to your middle phalanx to assess the arterial volume, and allows you to work out a stroke volume area. So this is how it works. The clamp method, rapid repeated measurements of pressure around the middle phalanx to maintain vessel size to a stable level, and then you can generate a pressure waveform that looks like this. And this is very similar to other pulse contour analysis technologies and allows you to work out the integral of the curve under the pulse contour. And then, of course, if you have a model of the circulation, but is based on age, gender, height, and weight, you can estimate the systemic vascular resistance, and then you can do a non-adjusted assessment of what the cardiac output will be using the pulse contour, the model of the circulation, and the heart rate. This also allows you to have blood pressure continuously. as opposed to intermittently, and that is also important. How good is this device for the measurement of arterial blood pressure? You can see that in relation to an invasive radial line. It's pretty good. It's pretty good. The bias is relatively limited, and the standard deviation, the limits of agreement are relatively limited. How good is the cardiac output? Compared to changes with continuous cardiac output using the thermodilution method, not so bad. So similarly bad, but not particularly worse. And this can now be reported, and it's available continuously and displayed on a monitor, and you can download the data continuously, and then you can look at what happens. So we took 10 patients. They're having chronic dialysis from CKD, and we applied the next thing to see what happens. Now, the prescription of the dialysis, the conduct of the dialysis, and everything was blinded to the information that we were obtaining, which was going into a box from which we downloaded the data afterwards because we didn't want to influence what clinicians were doing. So in this population, then we were able to look at the episodes of moderate decrease and the episodes of severe decrease in blood pressure. And you can see that there were quite a lot of episodes, but also quite significant amounts of time during a 4-hour hemodialysis treatment where the blood pressure was significantly decreased and the cardiac output, where the cardiac output was significantly decreased in these patients. So there is a state of, how can I put it, low cardiac output state or near cardiogenic shock, which is induced by the therapy, which can last up to 3 hours or an hour and a half and so on. So this is apparently happening in these patients. Do clinicians pick that up? Do clinicians have the ability to know that this is happening? And if you look at the blood pressure changes, there are only, as they're stable, blood pressure might increase. There is very little that can give the clinicians a sense of what is happening to cardiac output. Again, confirming what the review of the literature showed us, that there is a dissociation between pressure and cardiac output in patients receiving intermittent hemodialysis who have chronic kidney disease. And we also were able to measure blood volume. This is available in the dialysis machines using hematocrit monitoring, and the blood volume changes are displayed there. And you can see that there is a weak but present correlation between a severe decrease in cardiac output and a decrease in blood volume. And as you would expect, there is also correlation between the net ultrafiltration rate, the fluid removed during the dialysis session, and the decrease in cardiac output. Then we wanted to go to AKI patients recovering from continuous renal replacement therapy and have been shifted to intermittent hemodialysis. So this is a subacute phase. They've had their continuous renal replacement therapy for a week or 8 or 9 days. They're deemed to be hemodynamically stable. They've come off their vasopressors. The clinicians have said they're fine. They can go on intermittent hemodialysis, or they've left the ICU. They've gone on to the dialysis unit, and they're being observed. After a couple of days, the clinicians decide that the patient needs to receive intermittent hemodialysis. And then we went and we did the same thing. So we looked at the changes in cardiac index, whether they're moderate decreases, it's greater than 15%, or severe decreases greater than 25% in cardiac index, and how many episodes there were and how many minutes the patients were spending in a low cardiac index state. And these are acute patients as opposed to chronic patients. And you can see there that there are substantial periods when the patient is in the low cardiac output state. And this is severe decreases, which are very substantial in some patients, and moderate decreases, which are also very frequent and substantial. This is a smoothed out curve which provides a representation of these 10 patients where we monitor blood pressure and cardiac output continuously. And you can see that the blood pressure looks pretty happy, pretty steady, but the cardiac output is not. And of course, inevitably, because of the blood pressure cardiac output relationship that is used to calculate the systemic vascular resistance, there is a significant fall in systemic vascular resistance calculated in these patients. And as you've seen from the smoothed out curve, and as you've already seen before, the blood pressure is really not informative about what's happening to cardiac output in these patients. So we have evidence in people with chronic kidney disease, and we've got evidence in people with acute kidney disease recovering after CRT that there is trouble. What about continuous renal replacement? Is it good, or does it cause trouble as well? Well, you need to measure relative blood volume and ultrafiltration rate and cardiac output continuously in these patients as well. And you need a device that can do that. And there is a device that's available. It can be inserted in the circuit. I'll show you the picture there. You can put a component of the circuit, attach it, have a clip, and measure hematocrit continuously. And you can assess the changes in blood volume continuously, as well as cardiac output, as well as net ultrafiltration rate, as well as blood pressure. That's fun. So that allows you to look at what happens to blood volume when you're doing therapy in some of these patients. This is one patient where the clinicians felt that the patient was edematous and fluid volume patient's fluid balance had to be corrected, and net ultrafiltration had to be applied, and it had to be done rigorously. And you can see the changes in blood volume as assessed by hematocrit over a period of hours, and it's quite substantial, about a 10% decrease in circulating blood volume. So we looked at a cohort of patients receiving continuous renal replacement therapy systematically to see what happens on average to blood volume using hematocrit in these patients. And you can see that on average, blood volume decreases in patients receiving continuous renal replacement therapy. In some patients, quite substantially. If you take 10% as a cutoff, but a quarter of the patients or 10% of the patients, depending, will experience a very significant decrease in blood volume because of the decision of clinicians to remove fluid at a relatively brisk rate. And you might say, but usually we remove about 150, 200, 250 mils an hour. And I would say, yes, of course, but these patients cannot refill because they've got capillary leak. And if you've got capillary leak, it's very difficult to refill, right? It's a contradiction, isn't it? So this is the distribution of blood volume decrease, and then you can see there that quite a significant number of episodes of significant blood volume, peak blood volume loss being experienced by patients. And of course, not a surprise, the more you nuff, the more you decrease blood volume in these patients. So now let's look at the cardiac output, and there you go. The more you nuff, the more you decrease the cardiac index in these patients, as well as decreasing the circulating blood volume as assessed by the hematocrit. And of course, if you decrease the circulating blood volume, you decrease the cardiac index. And you can see that the net ultrafiltration rate effect is dependent upon where you are in your clinical cycle. And so if you're net ultrafiltering hard in the early period of CRT, when you've got capillary leak and you're unable to refill, you feel the consequences of net ultrafiltration much harder than you are in your recovery phase a week or so later. So let me conclude my presentation by saying that cardiac output is something that we believe is a major determinant of renal perfusion. Cardiac output, however, has been rarely monitored during intermittent hemodialysis in CKD patients continuously. And when it has been monitored, it's been intermittent. When cardiac output is measured continuously, there are clear and important decreases both during IHD for CKD and in recovering AKI patients. CRT, alas, is also associated with decreases in cardiac output. Such decreases appear mostly dependent on the rate of net ultrafiltration. They are particularly big when intensive net ultrafiltration is applied early in the use of continuous renal replacement therapy when people are very sick and may be unable to achieve capillary refill. We need to do more work in this field to see if optimizing cardiac output management and net ultrafiltration rate is associated with better patient outcomes. Thank you very much.
Thank you, Rinaldo, for this wonderful presentation. Are there questions from the audience?
Great talk, Rinaldo. So in your studies, did you look at patients with and without net ultrafiltration? Because there are studies that show the moment you take somebody and put them on a filter, there's myocardial dysfunction happening, even if you don't remove fluid. And then there's cardiac drop in cardiac output, and net ultrafiltration just makes it worse on things.
Yeah, I think that's an important additional area. I need to do echoes and have an assessment of myocardial strain, myocardial function, and see. You know, we haven't done that. It's quite laborious. You know, you have to have somebody do it and so on. But there's, as you know, there's been studies. Where's Louis? There you are. Louis published that stuff already, right? Where you actually see myocardial dysfunction, as mental areas of myocardial dysfunction during renal replacement therapy. So we got an inkling that this is happening. Probably there is obviously intravascular volume depletion. May well be also inflammatory vasodilatation. There is capillary leak and inability to refill. It's that horrible combo, isn't it?
We make it worse by
we just make it worse. And, you know, and we don't know how important that is in terms of patient. Let's forget a patient renal outcomes, you know, how long it takes for the kidney to recover. We don't know that yet. But it's clearly a fertile area of analysis. I think it is, yeah.
Rinaldo, do you have data on prolonged intermittent hemodialysis, whether the...
No,
Okay.
we don't, sorry, no.
Not yet. Okay. So if there are no further questions, I think we have to go to the next talk. Thank you so much.
So please join me in welcoming the next speaker, Professor Lui Forni from the UK. His talk is on Does My Patient Care What Renal Support I Offer? So Professor Forni, the floor is yours.
Thank you. I feel really sorry for the moderators. I was here at 2 o'clock, I've been for lunch, I've been for a walk outside, and they're still here. That's not true, but you are still here, so you're doing a great job. Well, one of them is, Melanie just kind of skived off the beginning. Right, so I'm going to talk about what does my patient care, what renal support that I offer them, okay? That's the plan. These are my potential conflicts of interest, none of which really dictate anything here. So here's my patient contemplating the effects on his cardiac output that are just about to happen, right? And is he thinking, well, I wonder if I'm going to have intermittent therapy, continuous, or SLED? Well, unless he's a nephrologist or an intensive care doctor, probably not, right? So what do patients actually care about? What do they actually worry about? Well, this was a very good article, I think, in New England by Margaret Herridge and our own Ellie Azulay, published a couple of years ago now. And this graphic shows the things that the patients are particularly concerned about after an episode of critical illness. And tucked away in there is kidney failure and the need for dialysis. So I think it's a slightly biased view. I would tend to have a slightly bigger box, but there we go. But so what do we worry about, right? What do we worry about when our patients get acute kidney injury? So we worry about whether they'll recover, albeit slow or fast, whether they won't recover, because we class that as non-recovery, ending up on dialysis, or not needing dialysis, but not really needing anything because they've died. So that, we view it, in a fairly simplistic fashion. What do patients worry about? Right? Well, clearly they worry about death and dialysis, but they worry about a whole load of other stuff, which is just as important. Whether they'll be in pain, what long-term drug burden is, whether they'll get their job back, whether they'll be frail, whether they'll get PTSD. So they worry about things that are slightly different to what we do. This is our current acute kidney endpoints that are held sacred by some of the bodies such as the FDA, incorrectly in my view, but there we go. The major adverse kidney events. So this is a composite of death, new requirement of kidney function, or persistent kidney dysfunction. Any nascent cardiologist in the audience will realise that the kidney doctors stole that from MACE, which is the major adverse cardiac events. And there are lots of risk factors for MAKE, some of which are patient-related, pre-existing CKD, liver disease, diabetes, etc. And there's lots of things related to the AKI itself, like the severity of the acute kidney injury, how long it progresses, need for dialysis, number of AKI episodes, for example. All these contribute to MAKE. So in order to answer this question, and answer several questions, we had an ADCI meeting where we looked at recommendations for clinical trial design. And of course, within that may well be designs as to what modality the patient's been exposed to. And we had general statements for AKI trials, but this was one of the first. And this was that we recommended that researchers, trialists, funding agencies, etc., acknowledge the fundamental importance and perspectives of the PWLE. So you may not know what that is. So PWLE is a patient with lived experience. So it's a patient or persons regarded as experts by having had first-hand experience with a diagnosis or health condition. So some of you may need PWLEs for grant applications in your countries, for example. Certainly in the UK we do. But seldomly have PWLEs or patients been involved in the design of trials in AKR or indeed ITU. But there's a strong rationale to include them because they can inform us as to what's important with them and in terms of health research. This was the PWLE we had in our ADCI meeting. Darcy Duquette, who's a survivor of critical illness in Canada, looked after by Sean Bagshaw. I do, of course, have his permission to show him. He was quite pleased with that. So he was involved in our discussions about what were endpoints relevant to patients. This is kind of spurned from that meeting. Dana Foreman wrote this with some of the usual suspects, looking at MAKE events as an endpoint and perhaps time to readdress that. And in fact, according to the patient, these were the things that were actually important. So death, whether the patient developed AKI, not recovering from AKI, and the slope of the GFR. So what that effectively means is the chances of them developing CKD in the future. Now, if you're 80 and you recover, you're probably less concerned about your slope of GFR. But if you're 25, then you're probably really very relevant, and you're chatting nicely to your relatives in case you ever need to ask them for a kidney. So the AKI we can kind of get rid of if we're just talking about modality. So if we consider the patient and evidence for one modality over another, what would we look for? Well, slope of GFR, so the need for renal replacement therapy long term, the non-recovery, and death. So is there any difference between modalities and these endpoints that are relevant to the patients? So is there any evidence, right? Well, what are the choices? These are the choices we have in a hospital with an endless budget, lots of nurses and lots of machines, right? Renal replacement therapy for acute kidney injury. Let's get rid of a lot of those and let's just concentrate on continuous and intermittent, and particularly intermittent hemodialysis and CRRT. I know some of you use prolonged intermittent techniques, PERT, but it's not commonly used, so I won't talk about that, and there's not a lot of evidence in that space. Personally, I think it has major advantages, but that's my own bias here. So what are the perceived benefits? So on the left here, we have the perceived benefits of continuous therapies. Hemodynamic stability. We may have conned ourselves, as Rinaldo's told us, into believing that. We wonder who started the rumours. Right? Stability of ICP, I think that's for real, and controlled risk of osmolar shifts, so we don't see the same disequilibrium syndrome that we used to see on intermittent therapies. But in intermittent hemodialysis, it has the benefits that it's a transition therapy and also can improve patient mobilisation and engaging with physio and whatever during the day. You can actually do that continuous therapies if you're well practiced. There's also rapid clearance of smaller metabolites. So if you want to clear potassium, because that's your main issue, and you've got intermittent therapies, that's what you have to do. And PERT kind of sits in between those two. So what modality? So those of you who follow the literature probably are aware that this is somewhat of a political hot potato, right? And so I'm kind of lucky because I declined entering some of these studies, so I can talk about it in a non-biased fashion. If we look at the evidence, right, for intermittent versus continuous, it sparked several publications and several debates. This was one in C. Jason, where intermittent compared to continuous, and Sean Bagshaw led a team of authors, including Ashita, who we heard so knowledgeably talk about citrate earlier, and the intermittent therapies was championed by Stéphane, who gave us a talk on timing earlier. So if we look at randomized controlled trials, I'm not going to go into the details comparing modality and mortality. Take it from me, there's no real clear message, okay? No clear message. But if we look at secondary analysis, because that's what we do, right? We don't have the evidence, so we slice salamis until we find the evidence. So we'll have a look at this. This is a secondary analysis of a Kiki and ideal ICU. Now, you know that the French approach is slightly different in that they're very well versed in using intermittent techniques. These are the methods and the average effects of CRRT versus intermittent. So they looked at patients whose first modality was CRT versus intermittent, and they saw no benefit in the French cohorts in terms of survival or of kidney recovery. That's what they showed. Alternative views come from the START AKI group. Right? Now, Stéphane already alluded to the fact this I was going to say this morning, but it was actually earlier this afternoon, that the intermittent techniques are more common in France and more practiced. This was a secondary analysis of the START AKI trial, and this did show a difference. It showed a primary outcome of this secondary analysis, which showed death at RRT dependence at 90 days favoured CRRT. So you were less likely to end up on chronic therapy at 90 days if you were given continuous treatment. And so they concluded that in critically ill patients with severe AKI, initiation of CRT as compared to intermittent was associated with a significant reduction in death or RRT dependence. So what our PWLE would applaud, less RRT dependence. And the take-home message, interestingly, was the optimal modality, blah, 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 but there was a lower risk. So if you read these, you kind of think, well, it's as clear as mud, really. You've got one group that say, well, actually, there's no difference. Another group say, well, there is in there. So what can we look at? Is there any other evidence? This is a fairly recent study. It was a data trawl through the Premier database in the US. Jay Coyner headed up this group, and they looked at claims linked to US hospital discharge data, the Premier data, and the cohort of patients is very much as you'd imagine looking at this cohort. They had over nearly 3,000 patients that were commenced on intermittent dialysis versus 1,000 on continuous. Continuous therapies were actually, a slightly sicker group, but despite that, they had less RRT dependence at discharge. So this was an independent group really looking at a Premier database. It's not randomized, it's not perfect, but it certainly showed that the odds of renal replacement dependence at 90 days was 30% lower in those treated with CRRT. So if you're a patient, you might begin to think, well, actually, maybe I'd have a continuous therapy. So what did the people in the debate say? Well, this was the Stéphane's view. And they came out with this, which I think is quite reasoned. No definitive argument definitively pleads in favour of one over the other technique. Right? Uncertainties persist, and it seems likely that no short-term outcome differs between the techniques, provided they are delivered in an appropriate manner. And that's the key, really. What did the other side of the argument say? Well, they said the availability of a spectrum of therapies should be embraced, and the strength of each modality should be marshalled in the right clinical context. So what's really bloody depressing about this is I gave a talk on this at the SRLF in Paris. Those of you with eagle eyes will see that was in 2014, right? When I had black hair and my own teeth, right? And so it was that long ago. And the lecture was called, When It's Time for Renal Replacement Therapy, What Is It Time For? And I effectively, these are my conclusions 10 years ago. No study has shown that IRT is superior to CRRT. And that's still the case, right? So no study has shown that intermittent is superior to continuous. Continuous is more expensive, and evidence suggests that long-term risk of end-stage disease is higher with intermittent. And really, not a lot has changed, really. And so my conclusion was, well, why bother comparing two cars, right, if you can't drive properly? And that's actually quite fundamental to this argument, I think. Because what would my patient want, right? The great quote by Vince Lombardi is, the measure of who we are is what we do with what we have. So what the patients would want you to do is demand that we offer the best care we can and the way we can do it. So if you're really good at giving intermittent therapies and not so good at doing continuous, then I would say that's what the patient would demand. And so as for me, well, in the last 10 years, what have I learned? Well, probably when the facts change, then I'll change my mind. 10 years ago, I thought continuous therapies were better for the patient long term, and I still do. And with that, I'd like to thank you for your attention.
Thank you very much, Professor. We all enjoyed your talk. Any questions from the floor? So you talked about the PWLE. So how do you choose those PWLE? Because there's a wide spectrum of patients with acute kidney injury, and sometimes those patients can be a sort of professional patients. So what do you think about the representativeness?
Yeah, that's the reason I'm laughing is because my last grant application, one of the criticisms was that the patient was too professional, right? I mean, how can you win? So because he was a professor of Max Fax that had become ill and whatever. So they said, no, he wasn't a typical patient. So I can tell you how I do it. Well, clearly I don't do it very well, but we have a follow-up clinic, and then every patient who comes to the follow-up clinic is asked if they would like to be on the research trial boards or whatever, and they're asked. And about 80 to 90% say yes, and then when it actually comes to it, about 10% will actually do it. So, you know, there's no science behind that. That's only the easy way for doing it with follow-up. If you have a cohort that lives further away, you're doing it by phone, it might be more difficult. But, you know, I'm relatively lucky in the UK that we have cohorts that are relatively close. That's how I do it.
Okay, wonderful. Thank you. So any questions?
Louis, if you include these patients in your clinical trials, do they read the whole project, or how do they give their recommendations?
Yeah, so they read the whole protocol and they have comments. You have to be patient because, you know, clearly there's bits they don't get, but also they do ask, I mean, it's out of the mouths of babes really. They ask very simple questions that sometimes you've never thought of, and so it actually can be quite interesting. So they do, yeah, they're supposed to read the whole protocol. I tend to spare them the statistical analysis, mainly because I tend to spare me the statistical analysis unless I'm really bullied into it. But yes,
Thanks.
a lot.
Okay, thank you very much, Professor Forni.
So I'm happy to introduce the next speaker, Professor Peter Pickers from the Radboud University in Nijmegen. I guess it's not so good spelled.
Very well pronounced.
We will learn something about stopping criteria for RT.
Thank you very much, Melanie. This will be a very pragmatic talk, actually, because there's very little evidence and studies on this topic. My conflicts of interest are not relevant. We learned a lot, I think, about the start of AKI, when to initiate AKI. And several large RCTs were performed, and overall the message is that you should only start if it's really needed. If you start too early, you would actually give RT to patients that do not need it. In the control group, they would not even need it, and there might also be a relationship with a worse outcome. So we know that. We know when to start RT. And what we use is still the old conventional criteria that are depicted here. And so there's a real need to start RT in these patients. This is clear and easy. But when to stop RT? So now my real disclosure is that all the data that I will show have considerable limitations. They are retrospective, post hoc, etc. Small sample sizes, very different patients, and there are variations of thresholds and predictive markers and conflicting results. What do we do now? Well, what we consider now good clinical practice is that we say, well, we look at the patient characteristics, depending on if he's hemodynamically stable, yes or no, the renal parameters, urine output, etc., but also logistics. So many times what we will do is that when we think we can stop renal replacement therapy and the filter dies, we would just say, let's not replace it, see what happens, and then if we have to, we will restart it again. So this is what we do normally based on staff availability, etc. And the consequence is that there's a wide variation in clinical practice. And so this is ranging from a wait and see policy to more a fast track procedure. And you can imagine that there might be an effect of outcome of these different policies, but we do not know that. There's no studies that shows that weaning early or later has specific effects. And at the same time, you can imagine that unnecessary renal replacement therapy, so if you prolong it, if it's not necessary, might be not beneficial. And also, if you stop it too early and you have to restart it again, that might also have negative impacts on the clinical course of these patients. And what are these unwanted consequences? Well, if you have AKI and you're stopping renal support, you have more fluid overload, you have persistent electrolyte abnormalities, other abnormalities, and you expose the patient to systemic effects of ongoing AKI. So these are all things that are likely unbeneficial to these patients. And so if you can avoid one or more failed attempts to stop RT, that might be better. But if you have a wait and see approach and you actually are too reluctant to stop it, and you might prolong renal replacement support for when patients do not need it anymore, maybe you would expose them to repeated hypotension, especially in intermittent forms of renal replacement therapy, bloodstream infection, bleedings, etc. So there are also consequences of giving RT too long. Now, these are the reasons why we start, what people say, we start RT because acidosis, etc. These are the reasons to start. If we ask what are the reasons actually to terminate renal replacement therapy, number one is that people say, well, urine output is enough. And so we think we can start. Others say also normalization of pH, volume status, or a normalization of creatinine and BUN levels. So what are actually the independent predictors that you would have to resume renal replacement therapy within 30 days? So you're stopping it, but you were wrong, you have to restart it. There are a couple of independent factors. If the patient is on RRT already for a longer period of time, it's more likely that he needs to be put on renal replacement therapy. Again, if you stop it too early, if he has a higher SOFA score, if urine output is less, I will come back to that in the next slides. If he was known with pre-existing chronic kidney disease, of course, there's less reserve there, and if the patient is older. So these are the factors that indeed make the chances of needing to reinstall renal replacement therapy larger. So urine output is actually the thing that most people look at, and it's actually pretty good in predicting if you can actually stop renal replacement therapy. The area under the curve is 0.88, and that means indeed that you have a pretty good separation. And if you look at this, this is another study, and it says if you're not using any diuretics and your output is 430, 450 per day, per 24 hours, then this has the best chance to stop renal replacement therapy and be successful in that. And you're correct in the classification of the patients, in almost 80% of the patients, if you use this cutoff value. But as you can also see, if the patient is on diuretics, this predictive value is completely messed up, and it's much less. And you can imagine it's also depending on how much diuretics, etc. So not surprisingly, the predictive ability is negatively influenced by the use of diuretics. So So this is important because many of these patients might actually be treated with diuretics in this phase of their disease. However, diuretics might still come in handy. We all know the furosemide stress test, that we give patients that are having AKI, furosemide, and then depending on their diuretic effect of it, we can predict if they will actually get better or have AKI in a more severe form, go from AKI 2 to 3, for example. So the response of the kidneys to furosemide is a predictor if there will be more AKI or not. We can also use that actually in the opposite way, that the kidney are recovering more. So this was a study that was done in the Netherlands. And the idea of this study was that if patients are actually taken off renal replacement therapy, then treat them with furosemide with the idea to get the urine flowing and thereby lowering the chances that they would have to restart renal replacement therapy. That study was completely negative. They could not prevent the restart of renal replacement therapy by furosemide. But when the furosemide stress test came out, we thought maybe we can use actually the outcomes indeed in predicting if they would have to restart renal replacement therapy or not. And this is the case. If you are giving furosemide to a patient that has just been taken off renal replacement therapy, and you can read the amount of furosemide they received, and you collect urine, if the production of urine is there, 650 mils it was, then it's very unlikely you will need renal replacement therapy again. If there's no diuresis, 48 mils only, during furosemide following RT, they're very likely to actually need renal replacement therapy. Again, predictive value of 0.84, really good. What is even better? So if you would measure endogenous creatinine clearance, that could also be used, of course, then you're actually measuring the functional ability of the kidneys to clear stuff. It's not only water that they are excreting. We don't know what's actually the optimal cutoff value, and as we think is between 15 and 20 mils per minute if we do that. So if we combine, as you can see here, if you look at creatinine only, is no predictive value at all. If you look at urine output, in this study, the area in the curve is 0.67. But if you look at creatinine clearance, and only for a period of time of 2 hours, so you don't need to collect urine for a whole 24 hours to use this clearance formula, then you increase the predictive value to 0.82. So the best thing is a combined thing of diuresis as well as creatinine clearance. That's the best predictor to do. Other future options, can we use a biomarker? Well, what is of interest is if you measure creatinine in patients that are put on renal replacement therapy, the creatinine values in that patients are decreasing because the machine is also clearing creatinine, of course. And so you cannot really know what the kidneys themselves are doing and what the machine is doing. There's another biomarker of renal function, is proacephalin, PANC, or PANKit is the brand name, and that one is actually stable on renal replacement therapy. So the idea is that if you would measure that and you do see a decrease, then it would mean that it's the kidneys of the patient itself that are improving. So maybe you could use that as a biomarker to decide when to stop with renal replacement therapy. And we did this secondary analysis of the trial of Alexander Sarbok and Melanie, who's chairing here. And we measured PANC in the samples of the patients that were in the Elaine trial. And what we found indeed is that if PANKit is higher, you're less likely to get off renal replacement therapy in the following days. But this was like one sample at the beginning and not like an everyday sample to decide it's going down, so now we can stop. So the study actually to do that needs to be performed so far. So my conclusions are that apart from knowing when to initiate renal replacement therapy, it's also of importance when to end it. Too short, too long, both are not good for the patient. Maybe a biomarker is coming, but we need studies on that and to see if there is any additional value above urine output and above creatinine clearance. And for now, the practical approach would be this. If you have a stable patient, stable hemodynamics, etc., the fluid status is, you're happy with that. then you can measure urine output very easily. If it's above 400, you're very likely to predict that that patient might come off renal replacement therapy. On diuretics, I would not say that you can predict anything because the area under the curve is too bad, but it could just be water without clearance. So what is better is actually to take a sample for 2 hours or 4 hours or 6 hours, whatever you want, and calculate the creatinine clearance. And then if that's above 15 or 20, then the prediction that you can do without renal replacement therapy is much better. And then you can stop and see what happens. And if you stop and you want to know for sure, you can do a furosemide stress test. And then depending on the urine output that is produced following that, you can even have a better prediction of that patient will stay off of renal replacement therapy for the next 30 days. And with that, I thank you for your kind attention. And as Louis was doing, I also have a quote from the internet.
Thanks, Peter, for this excellent talk. Are there questions from the audience? I have a question for your pragmatic approach. When you finish or stop renal replacement therapy, what do you do with the patients who receive diuretics as a pre-treating? So not for the acute situation, but they are pre-treated because of, I don't know, cardiac insufficiency or something like that.
Yeah,
do
so
you also use the 400 milliliters?
No. So if there's any diuretics, the urine output measure is not a good predictor. And actually what we do all the time is measure endogenous creatinine clearance. It's cheap, it's easy, why not?
Perfect. Louis.
Thanks, Peter. That was excellent. I've looked at the last 100 patients of mine treated with continuous therapies, and the reason for discontinuation in 35% was circuit failure. Yeah, and I think that's the problem, is if you're comparing intermittent to continuous therapies, the stopping criteria are very different. The other problem is, since Ashita has been such a fantastic advocate of citrate, people are now putting people on continuous circuits for days longer than they should be.
Yeah.
And industry, probably behind us, know that. 3-day filter life, but some people are being treated for 5 days. Yeah. So I think rigid criteria are really quite important, I think, and would be cost saving.
Yeah, I agree. And I do think indeed the very easy pragmatic approach is indeed the filter dies, let's not replace it, we'll look, we have another look tomorrow. But that means that you would have to restart, etc., and that might not be beneficial for the patient as well. So if you actually if you think you are in that phase that you're almost there, it would be better actually if the filter is still alive, to do the endogenous creatinine clearance, and then you can make the decision better.
Perfect. So if there are no further questions, thank you so much, Peter.
So now we're welcoming the final speaker for this session, Dr. Raghavan Murugan again from the United States. And this time he's talking about Let's Go Green. The floor is yours.
Thank you. Again, I thank the organizers of the meeting for providing me with an opportunity to talk about green RRT. So how green are we is really the thing that I would be covering today. In terms of my disclosures, I received several funding, but none of those would conflict with my talk today. So we as clinicians have all taken a Hippocratic oath saying that we should not be doing harm to our patients. But how do we react to that when we know that the intervention that you are doing for patients in the ICU is actually making patients sick by causing greenhouse gas emissions, because hospitals are responsible for 8.5% of greenhouse gas emissions, at least in the US, 5% of all global emissions. So it's a big elephant in the room. And 82% of those emissions come from the supply chain that we use. And ICU is also one of the biggest greenhouse gas emitters. 52% of the greenhouse gas are eliminated when we actually use reprocessed devices. So how frequently do we use reprocessed equipment in the ICU? So when we think about renal replacement therapy, we have to, in order for this to be sustainable, it has to be environmentally friendly. It has to be socially responsible. We have to be economical in order for us to sustain without compromising the quality of care. So a lot of people think that green means that I have to, provide less or more. But the important thing is that we should be able to provide high quality care that is, really, really green without sort of a compromising. What do I really mean by that? So for example, in one of the earlier speakers presented on continuous infusion of meropenem that they use, studies actually use, when you use continuous dosing, you are much, much greener as opposed to giving it 3 or 4 times a day. Because now you're involving disposables 3 or 4 times, the pharmacy charges, the pharmacy equipment, the compounding, all of those things, goes into, without no difference in clinical outcomes. So that's what we mean by when we say, we have to try to be green. So how green are we when we look at CRRT? So here is a data from one of the commercially available CRRT machine in terms of the greenhouse gas emission. And this data was published by Sustainable Healthcare Coalition from the UK. And what they found was that for a 72-hour CRRT treatment, the carbon dioxide emission is about 113 kilograms of the CO2 emission. And that is equivalent to driving a mid-sized SUV for about 452 kilometers. And if you look at where is this greenhouse gas emissions all coming from, you could see the use in the ICU, the production of the CRRT machine, the hemofilter, all of those account only for the 22%. The remaining 78% of this emission is actually coming from the production and the transportation of the CRRT fluid bag. And specifically, transportation of the CRRT fluid bags to the hospital accounts for about 50% of the greenhouse gas emission. So it's a big issue. We don't think about it, but this is what we are actually dealing with. Now, when you compare that with the hemodialysis, there's no data from the hemodialysis in the ICU population, but there is data in the outpatient setting. And you could see that this is one of the studies that were published looking at more than 209,000 hemodialysis treatment in 2022 in Ohio across 15 hemodialysis facilities. You could see the carbon emission from all of these, electricity, natural gas. Patient and staff transport contributes a fair amount. And if you compare that 58.9, this is equivalent to driving about 238 kilometers, about 150 miles of an average automobile. So this is the carbon emission per treatment of using hemodialysis. There's a considerable amount of variation in the patient and staff transportation, natural gas, and then the water consumption that are used in these treatments. And then there is also a fair amount of power use, waste generation. Here is the electricity use per dialysis treatment in Australia, between 12 kilowatts to 19 kilowatts. When you compare that with an average Australian household, the use is only 18.7 kilowatts per day in 2014. 18.6% of the total CO2 emission comes from the electricity. Interestingly, if you switch to solar panels, there's a 91% decrease in the grid consumption and about 75% decrease in the cost. And there's a return on investment in 7 to 8 years. Now, people may say that's a long time, but after 7 to 8 years, essentially the electricity cost is virtually down to zero if you convert that to a solar panel. Furthermore, there is a lot of dialysis waste that actually happen. 2.5, depending upon the country, 2.5 kilogram of hazardous waste per treatment in the UK. 38% of that is actually plastic. 1.5 to 8 kilograms per waste per treatment in Italy. So there is a considerable amount of waste that actually happens. So if you add all of this up into what is the annual CO2 emission for a patient who's receiving, or a end-stage renal disease patient receiving dialysis 3 times a week in the UK, it's about 3.8 tons of CO2. That is 7 times more than the mean per patient carbon footprint in the UK healthcare. If you look at Australia, very similar, 10.2 tons of, much higher, 10.2 tons, which is about 2/3 of the emission from the mean per capita annual CO2 emission in the Australian population. So we can see that there's a considerable amount of greenhouse gas emission. Furthermore, if you look into how much waste is actually happening, this is one example of water used during hemodialysis. For a dialysate flow rate of 500 mLs a minute, you need to have at least 1 liter of more of source water per treatment per minute to prepare the dialysate, which is equivalent to about 240 liters over a 4-hour dialysis session. Now, if you include the water that's used for priming, rinsing, sterilization of the circuit, this totals down to about 500 liters for a 4-hour dialysis session. And if you add that up to an annual, it's about 18,720 liters of water that's required. Interestingly, in the reverse osmosis system that is being used during hemodialysis, you can see that the tap water is fed through a carbon filter, then that's then forced through a reverse osmosis membrane through a pump, and then only purified water is then used for creating dialysate. It's important to note that about 80% of the water that is used in the reverse osmosis system gets rejected by the system. It's not useful anymore, and those reject water actually goes to the drain. Now, some of the machines that are out there can actually recycle this use and then will send it back through the membrane again, but not many machines do that. But vast majority of the time that this reject water goes on to the drain. And studies actually shows that reject water doesn't mean that it's actually bad. It is actually much better than the WHO standards for potable drinking water. So you can actually drink the rejected water. This water doesn't go to see the patient. So it's actually still the tap water that is forced through the membrane, but yet we actually throw this down the drain and we don't actually use it. Now, how can we think about making it a little bit more greener for our patient? Well, I would say first, prevent AKI if you can. Try to apply bundles and whatever interventions that you can to not start RRT in the first place. Delay RRT unless there's an absolute indication. Address goals of care. RRT in an 80-year-old is a bad idea, and based on carries a very high risk of death. Use minimum dose that's required to manage and prevent intradialytic hypotension, and then recycle non-infectious waste. Now, what are the recycling strategies that you could use for water recycle? So, for example, there are stuff out there where efficient systems actually recycle 80% of the reject water from hemodialysis. Now, it's a little bit more expensive, but the dialysis technology has to invest in this recycling thing so that instead of rejecting all this water from the reverse osmosis, they could be used. There are sorbent dialysis systems that's out there where actually the spent dialysate is actually sent through a sorbent that could then be purified, and then that purified fluid then can also be used for dialysate. Now, this is not something that's new. This has been around for about 25 to 30 years, the sorbent dialysis technology out there. But people don't use it because it costs a little bit more money. And then there are vapor compression distillation systems, which are actually portable water thing that could be used to purify the water. It's just a carry-on, and the power consumption of that is extremely low. There's a commercial name for that, but we don't use any of these right now. I think it's timely in that we consider these alternative techniques, given that being greener would likely to attract more incentives. Now, what about reusing the reject water? So if you decided to reject the water, we just send it right down to the drain. Now, there are hospitals, I think in UK and in Australia, that do sterilization, reuse it for hospital kitchen, laundry, toilet, and garden. In the US, it's used for nothing. What about reducing the dialysate flow rate of 500 ml to 400 ml a minute? Studies actually show there is actually no difference in clearance. And then we need to optimize the waste management and to recycle non-infectious waste. So this is a study that was looking at various clearance of KT over different dialysate flow rates of 500 ml, 700 ml automated flow, and then 400 ml a minute. You could see that there is no much difference in clearance. However, there is a significant amount of difference in the cumulative volume of the water use. When you compare 400 versus 500, it's only 96, whereas 120. And if you do 700 mLs of dialysis, it's about 168 liters. So it's a humongous amount of water consumption for no difference in clearance. Well, what about CRRT? We should be looking at centralized dialysate preparation, which none of us actually do, primarily because of all the compounding errors that we've had. Because I know in our institutions, patients were killed because they're putting tons of potassium or like tons of sodium. Now that has its own problems. But the more we do it, we can become good into it because as I showed you, most of the greenhouse gas emissions comes from preparation of those fluids, and transportation of the fluids account for 50%. So if we could prepare centralized dialysate preparation systems could make it much more greener, and then improve the energy efficiency of the CRRT machine, recycle and reuse disposable plastics, and then standardizing CRRT across the system have also shown to reduce the consumption and improve delivery of CRRT. What are some of the strategies that we can use for dose prescription? It's important that we use dry weight and not estimated body weight or the actual weight of a patient who's already 10 liters fluid overloaded to dose CRRT. For obese individuals, it's recommended if they're greater than 30% of the ideal body weight, use the calculated adjusted body weight, which is the ideal body weight, which is plus the 25% of the difference between the adjusted and the actual body weight. This was used in the ATN trial. Start with the effluent dosing of 20 to 25 ml per kilogram per hour if there is no urgent indication for high dose use, and then use dynamic dosing if necessary, where you give a higher dose of 30 ml per kilogram for severe acidosis, hyperkalemia, and then decrease the dose as the patient is improving, clearance is improving, and often to less than 20 ml per kilogram per hour. And I know that trials are ongoing, compare 10 to 15 ml per kilogram per hour with that of 20 to 25 ml per kilogram per hour. So we would need to see the results of those trials. And then include the intended net ultrafiltration rate in the effluent dose calculation to reduce the UF net rate in tandem with the delivered dose. What about recycling CRRT bags? So this is some of the figures given to me by Dr. Hunfeld over here. This is about a single Dutch ICU uses about 30,000 5-liter CRRT fluid bags per year. 3,600 kilograms of plastic waste is generated. And these could be only recycled if they are made of polypropylene polymers. If they are not made of polypropylene, you can't really recycle. But even more, that this sort of the connector is not recyclable. So you have to cut the remaining of the bag from the connector to make it more recyclable. And this is one of their ICUs where they have posted all these clear messages not to throw away the used CRRT bags and collect it in an area where they actually send to recycling. And we cannot do this on our own unless we have partnership with our clinician, hospital administration, and industry to be able to do it really, really green. So this is some data on standardization of the CRRT practices across the system, where it's been shown to reduce the CRRT duration and also reduce CRRT costs. One of the common misconceptions is that, well, if I go green, would that mean, does it cost more, right? And the answer is that not necessarily the case. And in some of these, things where it actually green means it's actually less costly, and so it might be actually attractive to the hospital administrators to go green. And then furthermore, it's very important that these initiatives are actually incentivized by, in some way by the hospital legislation and also from the government itself, so that these things give attraction. So what can we do? We can establish green RRT teams, focus on green education, have, sort of the green things as the environmental sustainability is one of the agenda meetings, develop green legislation, develop, green incentives, and we need really partnerships, and we need to follow the 10 R principles that have been put out, reuse, repair, refurbish, recycle, et cetera, in order to become more green. So, and furthermore, we also need to do green research, trying to understand not just looking at patient outcomes, but also looking at, is it environmentally sustainable outcomes? So in other words, when we design clinical trials, we need to be asking the questions, is this a green alternative? We should be able to write in our grants that this strategy would be green enough for not only good for our patients, but also good for our environment. We need to study this more on 500 versus 400, low effluent dose CRRT, develop different water retreatment systems and different methods of managing waste and packaging of the CRRT and so on. So with that, I'd like to thank you for your time and for the opportunity. Happy to answer any questions.
Thank you very much, Dr. Murugan. Any questions from the floor? Yes, please.
So thank you very much, very inspiring. Are you also considering to increase the maximum duration you use the filters in the CRRT from 72 hours to 96 hours or even more?
We don't do it at the University of Pittsburgh Medical Center. Dr. Tolwani may be able to answer it. You change it because the efficiency, filter efficiency actually decreases. So that is the reason why you can run the filter, but the clearance actually decreases. So that's why I don't think it's recommended to go beyond 72 hours.
Thank you.
Any other questions? So we adopt MAKE or RRT-free days as an outcome of clinical trials. Do you think we should include carbon footprint as a clinical trial outcome in the future?
It's very well been proposed, actually. I mean, I was at a meeting with when Dr. Hansfeld was there at University of Pittsburgh a couple of weeks ago. Derek was asking this question. When you design clinical trial, what is the cost? What is the environmental cost of doing this trial? And in addition to all the outcomes that we look at, we need to look at right into our grants about how green are we? If it may not be acceptable to generate, zillion gigatons of carbon emission. Now, it can get really, really muddy when you start talking about patient outcomes versus environmental outcomes, which is more important. But it is a balance, and I think we should look into these things because at least in the US, it's black, leave alone green right now. I mean, it's pretty bad out there, and nobody, at least here we're talking about it. Over there, we don't even talk about this because of the current climate issues. But I think that this is really something that we should be thinking about writing in the grants. The NIH, for example, in the US would be very interested in knowing what is the footprint of using, collecting blood samples, processing the blood sample. How are you managing the data? Managing the data on one server versus million going to other servers. The environmental emission of maintaining a server to hold your database. We don't include that in the grant submissions right now. But that's where the future is going to go, where every single stuff that we do, this is very, very superficial what we talked about. If you go into deeper in each of these things, there is a cost, there's an environmental cost associated with all of those things. And all of those things needs to be accounted for. And we are all collectively responsible.
Excellent. Thank you very much. Any other questions? Okay, thank you very much, Dr. Murugan.
Thank you.
Okay, I guess we have to close this session because we are running late. I would like to thank all the speakers for the wonderful talks. And I would like to thank you for being part of this session. And I wish you a nice evening and a nice ongoing congress. Bye-bye.